Hello.
Okay.
No. Good morning, all. Sorry,
Good
actually.
evening,
Good
Akhil.
evening.
Good evening, Akhil.
Good evening, ma'am. Actually, we are just in some technical glitches are there. We'll be sorting it soon. Audio clear ആണോ? Audio clear ആണോ? Echo ഉണ്ടല്ലേ? എക്കോ ഉണ്ടെന്ന് തോന്നുന്നു അല്ലേ? ഹലോ 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 ഹലോ
എല്ലാം കൂടെ വേണം.
Good evening, Srimari Madam. Madam mute ആണ്.
ഹലോ
Good evening, sir. സാർ എങ്ങനെയാണ്? സുഖാണോ?
സുഖം തന്നെ. മാഡത്തിന്റെ ടോക്ക് കേൾക്കാൻ വേണ്ടി കയറിയിരിക്കുന്നു.
അയ്യോ, അങ്ങനെ പറയല്ലേ. ഞാൻ മറ്റുള്ളവരുടെ സാറിന്റെ ഒക്കെ ഇൻപുട്ട് കിട്ടാൻ വേണ്ടിയിട്ടാണ് കയറിയത്. ആക്ച്വലി സാറിന്റെ കോളേജ് ആയതുകൊണ്ടാണ് എന്നെ സ്റ്റിമുലേറ്റ് ചെയ്തത് ഇതിൽ ചേരാനായിട്ട്. എന്റെ പഴയ ആലപ്പുഴയിലെ സ്റ്റുഡന്റാണ് എന്നെ വലിച്ചിട്ടത്. അപ്പൊ ഞാൻ നോക്കിയപ്പോൾ PKDIMS കണ്ടപ്പോൾ സാറിനെ പഴയ ഓർമ്മ വന്നതും നമ്മുടെ പഴയ ബന്ധം പുതുക്കാലോ എന്ന് വിചാരിച്ചാണ് ഞാനത് ഏറ്റെടുത്തത് തന്നെ. എനിക്ക് പുതിയതാണ്. The full credit is to Andrew, sir. അല്ല, ഓണസ്റ്റ്ലി ഞാനുള്ള കാര്യം പറഞ്ഞതാ.
എക്കോ കേൾക്കുന്നുണ്ടോ?
ഇപ്പൊ നേരത്തെ ഉള്ളതിന്റെ അത്ര എക്കോ ഇല്ല.
ഇപ്പൊ എക്കോ ഉണ്ടോ മാഡം? അതാണ് ഞങ്ങൾക്കൊരു
എനിക്കിപ്പോ എത്ര എക്കോ കിട്ടുന്നില്ല. കിട്ടുന്നുണ്ടോ?
കുഴപ്പമില്ല, നല്ല സൗണ്ടാ, കുഴപ്പമില്ല.
ഓക്കെ, താങ്ക് യു സർ.
എന്റെ ശബ്ദം കേൾക്കുന്നുണ്ടല്ലോ അല്ലേ?
ഉണ്ട് മേഡം.
മാഡത്തിന്റെ ശബ്ദം നന്നായിട്ട് കേൾക്കാം.
താങ്ക് യു.
സോ മാഡം, നമുക്ക് 2 മിനിറ്റ്സിനകത്ത് സ്റ്റാർട്ട് ചെയ്യാം മാഡം. ഒരു 1 to 2 minutes.
Hello. Hello.
Good evening, all.
ശബ്ദം ശരിയല്ല കേട്ടോ.
Is there
Not
any
now.
issue? Good evening, all. Myself, Dr. Agil. I'm an assistant professor in the Department of Emergency Medicine at PKDIMS Institute of Medical Science, Kerala. And we'll be starting in a couple of minutes. Actually, we are waiting for all our faculties to join. Within a couple of minutes, we'll be starting. Just, I think, 6:07 will be starting. Hi. Hope I am clear. My slides are also visible.
It's clear.
Thank you, ma'am. Good evening, all. And it's a proud moment for us to start a webinar series on the topic, basically on restoration topics. So when we plan about a webinar series, first we were in doubt when to start, how to start, and what is the topic to be included as in an emergency medicine scenario. So when you come to PKDIMS Institute of Medical Science, we get a lot of out-of-hospital cardiac arrest victims in the hospital. Mostly around 25-30 patients per month. So there is always a dilemma when you start resuscitating out-of-hospital cardiac arrest victims. Not only based on the science of resuscitation, but also on the legal aspects, religious aspects, and a lot of things are there. But there are always guidelines are there. But still, in some scenarios, we'll be in doubt what to do next, and we will also always go for expert consultation. So that's why we choose this topic, that is to resuscitate or not out of hospital cardiac arrest victims. And this topic, when I put this topic to resuscitate or not out of hospital cardiac arrest victims, one of the faculty from US messaged me. There's no point that we can't resuscitate a patient of cardiac arrest because the right to life like this, definitely we have to resuscitate. But that's not the situation in most of the countries, because there are situations in which the signs of death are there, we don't go for a resuscitation, and still it's valid in most of the countries. But when it comes to guidelines, there are also always it's a black area where there's a proper guidelines for starting resuscitation of these patients. So that's why we choose this topic. And after getting this topic, then our doubt is which are the faculties to be called. As you know, in the EM fraternity, we called almost all the faculties of emergency medicine, and we got a very good number of faculties across the India. And we got faculties from AIMS, Manipal, Jubilee, and various medical colleges in our country. And when it comes to PKDIMS Institute also, we got a bunch of faculties here. And it's only because of the support from the management that we can't conduct this online webinar series. And this is a series only because we are starting this webinar series based on this topic, and we'll be continuing on the next month also. And today in this series, we have a lot of faculties across the nation. And first of all, I just want to thank Dr. P. Krishnadas, sir, who is the chairman and trustee of Nehru Group of Institutions. As you know, PKDIMS Institute of Medical Science is a 950-bedded hospital in Kerala. It's one of the largest private medical institution in Kerala. And we have around 200 UG admissions, MBBS admissions per year. And we got a lot of support from all the emergency medicine faculties across the country. And here, when we start this topic, it's the support of our director, sir, that we can conduct this topic, and we got a good emergency medicine department in our institution. We got 6 ED physicians, NMC recognized ED physicians in our department. So when we start this topic, we always, I told director, sir, please, sir, come and have a certain words with you. So I cordially invite my director, sir, and Dr. R.C. Krishnamar, sir, for a few words of inaugurating this session. Thank you, sir.
Thank you, Dr. Akhil. Thank you, Dr. Akhil. Am I audible?
Yes, sir.
Thank you, Dr. Akhil. Am I audible?
Yes, sir.
Yes, sir.
Thank you.
Chandni madam, I'm Sri Kumari. I remember you. I don't know if you remember me.
Thank you, ma'am, and most welcome, ma'am. Thank you. Okay. I'm happy that PKDIMS Institute of Medical Sciences has started a webinar series on emergency medicine. I think the first session is to be held today, and I'm extremely happy to know that many senior faculty members have joined the webinar, and I am sure that with the support of all of you and with the enthusiasm and energy of our emergency medicine department, this webinar series will become a grand success, and I wish them all the best. And today, the first talk on the series is to resuscitate or not out of hospital cardiac arrest victims. The resuscitation of out of hospital cardiac arrest victims in an age where digital platforms connect us globally, it is fitting to discuss this vital topic here. Out of hospital cardiac arrest strikes suddenly, leaving individuals on the precipice of life and death. The decision to intervene or not is laden with ethical dilemmas and profound consequences, as we all know. Throughout our discussions, we will navigate the complexities of resuscitation, exploring cutting-edge research, innovative strategies, and ethical considerations. we must weigh the potential for recovery against the quality of life post-resuscitation, balancing medical expertise with compassion. As we delve into these topics, we must confront difficult questions. What factors influence survival rates? How do we respect patient autonomy in emergencies? What role does technology play in enhancing resuscitative efforts? Furthermore, we must address disparities in access to timely interventions, particularly in marginalized communities. Let us not forget the human faces behind the statistics. The families shattered by the loss, our commitment to improving outcomes extend beyond medical facilities. It is a testament to our shared humanity. In conclusion, I encourage each of you to engage with an open mind and a compassionate spirit. Together, let us strive to resuscitate not only bodies, but also hope and resilience. And once again, I thank the organizers and all the participants, and I'm sure that in the future, this webinar series will become a landmark webinar series, not only in the field of emergency medicine, but in the entire field of medicine. Thanking you and wishing you all the best once again. Thank you.
Thank you, sir. So we'll be going to the webinar topics one by one. As you know, we have 8 topics today discussed by a lot of faculties. And I will introduce the first topic. So this is the first topic of the day. Is it broad dead or out of hospital cardiac arrest? Existing criteria to initiate resuscitation in an out of hospital cardiac arrest victim in emergency department. Here, the panelist one, my own Chandini madam. She is the professor of medicine and head of the department of emergency medicine at Government Medical College, Calicut. What to say? I can't actually tell more words about him because she's my mentor only. So, thank you, madam, for coming to our webinar series, ma'am. Hope you are hearing.
Thank you.
Thank you, ma'am. Next, our panelist is Dr. Mohammed Hanif. He's the assistant professor in the Department of Emergency Medicine at Dr. SMCSA Medical College, Karakonam, Trivandrum. And he's one of the first batches passed out from the emergency medicine in our country. And he's one of the going to be good panelists. And our moderator will be Dr. Mohammed Jassim. He is the senior resident in our department at PKDIMS Institute of Medical Sciences. Over to you, Dr. Jassim.
Thank you, sir. Today, the first topic for today is it broad or out of hospital cardiac arrest? And the existing criteria to initiate the resuscitation in an out of hospital cardiac arrest victim in an emergency department. So today we have Chandri madam and Hanif sir. Hanif sir being here is a happy moment for me because he's my mentor and he was my head of the department when I joined my PG at Medical Hospital. Welcome, sir, and welcome, madam. Thank you. So, we'll discussing the question, few questions. So, before that, we'll come to a scenario. So, it'll be easy for us to sort the questions based on the scenario. So, I'll just explain the scenario. Suppose a 60-year-old patient comes to the ED after sudden collapse at home 1 hour back, and he's a known case of diabetes, hypertension, dyslipidemia. And his daughter, being a nurse, started CPR in ambulance on way to hospital. On arrival to ER, the patient had no pulse and no breathing. So this means the patient is in a cardiac arrest. So the importance of this scenario is, in the scenarios we have discussed that the patient's bystander is a nurse. So she's a medical professional. So as we come across various studies regarding the broader and out of hospital cardiac arrest, the cornerstone of the patient attaining a return of spontaneous circulation is the bystander CPR. So I just kept this scenario specifically because it is mentioned in the scenario, the patient received CPR while in the ambulance. So the patient had a collapse at home and the bystander is at home, and even the medical professional was not aware that she has to give a CPR as and then. And the patient received CPR only in the ambulance. So I kept a specific scenario so to just discuss the importance of the cornerstone, the cornerstone of the ROSC, that is the bystander CPR, and the impact of no flow time on attaining ROS. So I have prepared 10 questions for this topic, and we have Madam and Sir, Chandri Madam, Hanif Sir, discussing this topic. So I'll be interacting like alternate questions with Sir and Madam. So coming to Madam, Ma'am, the first question that I prepared is, when do we say the patient brought to
Jasin, is it my problem or I can't hear you?
No, madam, even I can't hear.
Okay, okay. That's a question. That's why he has gone out of the. It's a very difficult question to answer. Maybe Hanif can start. By the time maybe Jasin will join.
Madam, you can start because you got your first question. You can start. We cannot hear.
Maybe Hanif also
Madam,
can, because
Yeah.
Definitely.
And if sir also can join.
I'll add to it, ma'am.
Jasin, okay.
Ma'am, you may please start.
Yeah. Broad debt is always a very difficult question. Maybe in the current time. Olden times, it was very easy nowadays because we were not doing this sort of active resuscitation in patients arriving to the hospital. But the question is to be to intervene or not intervene. But in today, I feel we have to intervene in every case rather than declaring broad death, except in situations where we have definite signs of death, or there are situations where we are very sure that our attempts are not going to succeed because of the anatomical and other mutilations that is happening out of the injury or whatever it is. So maybe broad death may not be that easily regulated. We all know out of hospital cardiac arrest, the word says there is mechanical.
Can't hear, madam. Can't hear.
Oh. Now, my voice also gone.
No. Okay, you are very faintly. You can. Previously, you were very audible.
Let me see what happened. Can you hear me? Can you?
Yeah, I can hear you, ma'am.
Okay. Maybe I'll just try, but I feel the term out of hospital has cardiac arrest, and the definition itself is mechanical cardiac arrest. Mechanical cardiac.
Chandri madam, your volume is low.
Let me see. Very now it's audible. Okay. Volume is low.
Now it's fine.
We can hear ma'am now.
Okay. So there is most of the cases there is mechanical cessation of cardiac function, and there is absence of the systemic circulation. So this is being identified, and things has happened out of hospital. So we actually do not know the exact time, because patients or the relative may not be, or the person who is bringing the patient may not be able to tell us. But I feel in all the situations except the one specific that I have told, where there is definite establishment of death by the signs of death as the time since death, or there is definite evidences of very mutilated body, we have to take it as out of hospital cardiac arrest, and we have to start resuscitation in all the patients that we receive in our emergency department. But before that, I just want to congratulate and thank you for giving us this opportunity and joining all of us into the very important webinar series.
Thank you, madam. So, Hanif sir, would you like to add some of your points regarding this?
As ma'am rightly said in the beginning, it's a very, very difficult scenario to tell or tell this is a broader case. Because there are certain situations where you feel like resuscitating the patient, but you cannot because certain things prevent us from or we cannot do it. So, what if you ask me any clear clinical indication? Yeah, there are few definitions. So, if you ask, the broader means a patient who is already clear with no clinical signs of life. So defining clinical signs of life, we have a lot of clinical practice in many hospitals. In some hospitals, they check the pupil, some where they look at the other clinical signs, and in many places they look at the ECG. So are we wasting time? It's a big question we come across many times. But we have to make a very difficult decision in making sure calling the particular patient a broad death. So once we consider the patient as a broad death, then our resuscitation we are not going to do. So if you look at the standard definitions or where you can consider broader, clearly is where the patient is having severe decapitating injury or has got a very mutilating injury where the patient survival is almost there. For example, a decapitated body or an injury, very bad crush injury, or a patient who cannot be surveyed or who's already rigor mortis has set in, or libidity is there. Libidity, when the body lies there for a long time, the blood collects on a lower area and you can see a little color changes in the dependent area. So all these factors, in those patients, definitely we are not going to give CPR. But there are other conditions where we should consider and we'll have to initiate resuscitation. And most important point is when you have a do not resuscitate consent form or a pre-declaration, then we should not resuscitate these patients. They are all considered as a broadhead patient. So this is how we can in a broadly consider a broadhead patient.
Thank you, sir. So coming to the next question, we have a little bit limitation for time, but coming to the next question, should we attempt resuscitation in all patients coming in cardiac arrest? So it's a vague question, but still, sir, do you have some points to add on this?
Yeah, if you look at the recommendations, they say only one absolute contraindication that is very much written everywhere is when patients having a DNR. When the patient they not resuscitate. In every other patient, we should consider resuscitation. That's what is written. But already I discussed a few clinical scenarios where the patient cannot be resuscitated. We already told, and there are a lot of other factors. These other factors include your local situation, your local practice, local rules. In certain countries, there are the rules where they do not allow patients or they do not recommend resuscitating or giving resuscitation to patients for of a particular age. So these are all varying from place to place and clinical practices, and even somewhere it involves your what do you say, your ethnicity, your religious beliefs, and all these factors. So it's a very broad area. It's a very sensitive thing, and you cannot tell this is the point or the patient who we cannot do a cardiac resuscitation.
Thank you, sir. Chandri, madam, would you like to add some points regarding this? Madam, you're mute, ma'am.
You're not audible, madam. Please.
Madam, mute on the matter, ma'am.
Okay. They has covered all the points, and do not attempt resuscitation also very commonly seen in our patient pools. I don't think we ever get such patients, which is very, very rare. And that's the most important challenge we also face. So we cannot make decisions in that minutes, that very life-saving moments. So we have to attempt resuscitation in most of the case, except that, as Anish rightly pointed, where there is a clear evidence of death, which we have been taught in our days. Okay, we'll move.
Excuse me, sir.
Yes.
Hello.
Yes.
Ma'am, I just have a doubt, ma'am. Maybe the doubt might not be correct. Ma'am, it's just that in situations, ma'am, am I audible right now?
Yes. I just see whether we are taking questions now or after
not
that.
Not now.
Okay.
Fine.
So we can take
okay.
doubts in the last.
Okay, Vishnu.
Okay, thank you, ma'am. Coming to the next question, Suppose if the arrest is witnessed or if it is not witnessed, how will it affect in attaining the ROSC?
Yeah, this is very important question, and the point you have already made it very clear. If the witnessed arrest and the CPR is started by a trained professional, always there is a very high chance of survival. And this has already been done in many studies, and it has proved maybe 10 times if the witness is a health professional or it's a emergency medical service provider, there is a high chance of survival. And even bystander CPR has got better survival than a situation where there is no CPR patient received before reaching the hospital. Okay, I think it's clear.
Sir, Hanif sir, coming to the next question. Sir,
Yeah.
if the initial, is there any chance whether if the initial rhythm is a shockable rhythm, does it increase the chance of attaining ROS, sir?
Definitely, there are a lot of studies have been done on this topic. Where there's a difference in a patient presents to your ED with a shockable or a non-shockable rhythm, and most of the studies are in favor of patient presenting with shockable rhythm having high severe survival rate. So when we look into detail, what in many studies they emphasize is that since the patient is having some sort of minimal cardiac activity, it maintains a minimum perfusion. In a non-shockable rhythm like asystole, there is completely no activity. So, but in a PE and ventricular fibrillation or ventricular tachycardia, there is some cardiac activity, and which is allowing the cellular perfusion. So these rhythms definitely make a difference in the survival rate, especially in ventricular fibrillation and ventricular tachycardia. Some studies say that the patient presenting with these rhythms have higher chance of survival than the person with asystole or a PEA.
Okay, sir. Coming to the next question, ma'am. Like when I started preparing for this topic, is it BD or OHCA? So most of the studies that I came across, in all studies, the most important factor in attaining ROSC is the no flow time. Kindly, a few words regarding that.
The term is actually saying it's a time from arrest to starting CPR. So that is the no flow time. And it is also shown that if there is every 1 minute delay in starting CPR from the time since arrest, there is a chance of the chance of regaining the rhythm or recovery is coming down. That means some studies says that every minute there is lesser chance, even otherwise the chance of survival is less without of cardiac arrest, and every minute further 30% is reduced as the chance of survival. So this is a very important time, but very difficult to get the time since arrest, because most of the time patients will be, relatives will be telling as they feel. Nobody will be looking at the time since arrest. So time from arrest to starting CPR is actually the no flow time. Okay.
Thank you, ma'am. Coming to the next question. So as we already regarding the importance of no flow time. So the CPR given by the bystander plays an important role in giving decreasing the no flow time. So what are the relevant studies regarding this, sir?
Yeah. So if you look at it's encouraging. Say why BLS has been so much country is to improve the sensitization of CPR. So in initial days when a patient is in arrest, people used to do mouth respiration. Then they used to give cardiac arrest. Then studies found that they need only compression and coronary perfusion. So even giving mouth-to-mouth respiration was difficult for many people. It's not very easy, especially even during the pandemic times and also only compression compression enough to maintain patient's high coronary cerebral perfusion. So now recommendations are telling people, teaching people only to give compressions. That is the level of importance of starting an early CPR. And all of us know that if especially if this patient is having a like shockable rhythm or where the perfusion maintained, the patient reaches hospital, we can have a better survival rate. Yeah, definitely it's a multi-factor. It's not that every patient who's given CPR coming to hospital service or the patient who was out of cardiac arrest for whom CPR is not given and resistance starts from the ED, he may survive. So it is all depending, but still when you look at the data or studies or even our clinical experiences, if a CPR has been started in a very early phase, it has definitely helped the outcome of improve the outcome of the patient.
Thank you, sir. Coming to the next one, ma'am, like the comorbidities of a patient. So certain patients will be, we find it like most of the time the patient might not attain the ROSC. So what is the effect of the comorbidities of the pre-existing medical conditions in patients which will hinder the ROSC? Your thoughts on this?
This is very, very important, and I think some of the situations we prefer do not attempt resuscitation is there, because in patients who are terminally ill or bedridden for longer term, advanced diseases, complicated diseases.
Ma'am, the sound is a bit low, ma'am.
Okay. Advanced diseases, frailty, terminally ill, cancers, all these situations, we all know that the chance of survival is very worse if we do resuscitation. And secondly, even if there is return of spontaneous circulation in ROSC is attained, but patient outcome, long-term outcome, that is more important, that is 30 days or 1 year, it is going to be more difficult in situations. So outcome is actually dependent on the premorbid illness of the patient or the conditions that the patient is suffering from, especially in advanced diseases.
Thank you, ma'am. Sir?
Yes.
So coming to the next question. So does the factor age affect the resuscitative efforts, sir? So should we consider the age?
Yeah, in that's what I link. It's a very local decision and all typical on the population. Certain countries there are rules where they do not recommendation of even patients above age of 65 to 70. So in the old age group with multiple problems, they don't recommend resuscitation. So, and it's also on the basis of the prognostication. In a multiple comorbid patient who's a very elderly patient, yeah, definitely if their bystander wants a resuscitation, we can attend. But the survival rate and their outcome is going to be very different than a younger patient. That's for sure. So considering all these factors, maybe we should, so we can tell age. Definitely, age has an impact in the outcome of the patient and resuscitate effort. So in certain patients, if some early directives are there or they are not willing, the patient relatives do not want to resuscitate the patient aggressively, then I think we should make a informed decision on that.
Thank you, sir. Coming to the last two questions, ma'am. As we know, like in our Indian scenario, the pre-hospital care is even below the beginning stage. So, what are the importance pre-hospital care which may increase the outcome in attaining the ROSC? Your thoughts on this, ma'am?
Pre-hospital care is very important, and as we have already discussed about no flow time, because what we want is the long-term outcome. That is more important rather than attaining ROSC. So if there is an early resuscitation, early attempts, and early pre-hospital care, that actually improves the outcome, and the 30-day outcome measure is actually improved if the pre-hospital care is initiated. I think more people should be trained, and more should be people trained to do the high-quality CPR and to recognize the cardiac arrest. So that will improve the outcome.
Thank you, ma'am. Coming to the last question, sir. Hanif, sir. Sir, can you hear?
Yeah, please go
ahead. Sir, like when in coming to the Indian scenario, so the religious, societal, and the cultural factors, often these affect the active intervention in ED. So what are your thoughts on this, sir?
See, this is a very, very challenging topic, because many times when patient comes into ED, especially a ma'am has rightly told out, in our Indian center, this kind of practice is not very, very common or very prominent. So we might be like in a position to start resuscitation. So and we'll be doing aggressive resuscitation in this patient. And by the time when we come into contact or when we start discussing with the bystanders or the relatives, that's the point where we understand there is some early directive or some early understanding that this patient need not be revived or given aggressive resuscitation. So what I would recommend it is or what is a clinical practice is best to have an early conversation during the initial resuscitation phase itself. Have early conversation regarding the patient's choice, or if any early directive is there, even if it's a verbal directive, make an early communication and try to understand what the patient relatives want. In certain cases, we should definitely consider, especially in elderly population that we already discussed. In elderly population, do our patient who's already chronically sick, who is bedridden patient, who has been just brought in emergency because he suddenly become unresponsive. So already who is having a very low quality of life, who got severe morbidity and all these issues in these patients, and if they got religious some reservations in resuscitating the patient, because in certain religious belief they believe it's not good for the dignity of the patient to have an aggressive resuscitation when the patient is at such bad state. So we as an ED physician, what I would recommend is considering all the multi factors during aggressive resuscitation itself. You have to consider all the factors, and that is something which we learn over the period of experience, and with the proper teamwork, understand the situation and do the best in the interest of the patient. Thank you.
Thank you, sir. Thank you, madam. This is a very vast topic. We try to discuss in just under 15 minutes. Since we have a problem with the time, so we'll be moving on to the next topics. Thank you, sir. Once again, thank you, sir, madam. We'll be moving to the next topic. Dr. Sanjay
Thank you, Dr. for this. Okay, thank you so much. Thank you, ma'am.
Thank you.
Thank you, Chandri, madam, and Hanif, sir. Next topic will be, we already started registration, then what to do next. That is very much important. Can you do the next slide? So this topic, here we are going to discuss this topic with Dr. Sachin Menon. He is the AHA India consultant, regional director ECC, and visiting professor at MGM Medical University, Mumbai. Sir, can you hear me, sir?
Yes, I can hear you, Jindal. Thank you. I can hear you. Hello, can you hear me?
Thank you, sir. Yeah, sir. Yeah. Okay, sir. Next is, we will be discussing Dr. Vimal Krishnan. He is the professor in Department of Emergency Medicine at Kasturba Medical College, Manipal. And this session will be moderated by Dr. Sanjay KS. He is the Senior Resident, Department of Emergency Medicine at PKDIMS Institute of Medical Science. Vimal, sir, can you hear me, sir?
Loud and clear, loud and clear.
Vimal, sir?
Loud and clear. I hope I was audible.
Yeah, sir. Thank you, sir. So, over to Dr. Sanjay.
So, good evening, everyone. So, due to shortage of time, we are directly going to the session. Good evening, everyone. Due to shortage of time, we are directly going to the topic. So, we have two scenarios. Scenario 1. It's a 55-year-old male and a 3-year-old male with no comorbidities met with an accident, and the bystanders brought them to the hospital. It took approximately around 20 minutes to reach the hospital from the accident site. On arrival, for both of them, central pulse was not felt, CPR was started, and initial rhythm showed assisted. This is one case. Scenario 2, it's a 70-year-old male patient on case of CAD, CKD, DM, and hypertension on regular medication, was brought in unresponsive state. Bystanders gives history of sudden onset of chest pain, followed by patient become unresponsive. It took around 10 minutes to reach the hospital. Bystander CPR was ongoing. On arrival of ED, central pulse was not felt. CPR was continued. Initial rhythm showed VF. Sir, for the first question is, depending on the mode of injury and along with the other co-founders like age group and comorbidities, is there any guidelines to substantiate resuscitation efforts, sir? To Vimal, sir.
Firstly, thank you. Thank you for allowing me to share space with my teacher.
You're not audible. Vimalata, you're not audible.
Hello? Am I audible now?
Yeah.
Yes,
yes.
Thank you, PKDIMS, for holding a webinar of importance in a gray area. Thank you for giving me the space to, come to this room along with teachers here, my teachers here. One of the questions that you had asked now is with regards to the traumatic and atraumatic cardiac arrest. Both the scenarios are traumatic cardiac arrest, right? The scenario 1 has got 2 victims of traumatic cardiac arrest, adult and pediatric. There are, if you look at evidence, the classical techniques of resuscitation, which is very applicable to the medical context, might not be completely applicable in the traumatic context because the causes of cardiac arrest and trauma are different from that of medical emergencies. So it might not be prudent to just consider doing CPR, chest compressions alone, or doing bagging alone. You might have to deal with the causes directly. Like, for example, a tension pneumothorax, you'll have to decompress the chest. If it's a tamponade that you've diagnosed earlier, you'll have to reduce the tamponade. if it's pure hemorrhagic shock, we'll have to consider blood early. These are all starkly different from the cardiac arrest scenarios that you get in the medical context, and that is the change that you have when you're managing traumatic cardiac arrest. Also, the newer modalities which have come in, which we discuss with time, are also taking a lot of precedence in the traumatic cardiac arrest scenario. One thing that I want the residents of the team who are in the room to take home would be that massive trauma that is incompatible with survival. For example, decapitation, exposed brain matter, hemicorpectomy, in addition to no signs of life. That means non-reactive pupil in the last 15 minutes, no spontaneous respiratory effort, no organized ECG. Maybe it might be a good call to withhold resuscitation and not lose a lot of resources. Over to you, Chanchal. I hope I was audible, Dr. Chanchal.
To Sachin sir, is there any contribution from your side, sir?
Am I audible, Chanchal?
Yes. Yes,
Yeah, perfect. So thanks, Vimal, for summarizing it. I don't know if I would have been able to do that. So the thing is, as he mentioned, it's a pretty gray area, and what we need to understand first is that most of the resuscitation attempts are actually unsuccessful, and because of that, we should know actually when we need to stop. So again, it's a decision that is individualized. It has to be tailored according to the specifics of the individual victims, but it has to be based on sound clinical judgment. And unfortunately or fortunately, the onus of that falls on the team leader, but it's not actually alone when he takes the decision. It can be done in consultation with the team. But if in doubt, always maintain the initial resuscitatory efforts until you have adequate information available, when you can say that we can actually cease resuscitation. Because sometimes in some cases, for example poisonings, in hypothermia, patients potentially have a very good outcome with even prolonged and aggressive resuscitatory efforts. So just to add to what Vimal said, there are some key determinants that for survival. Again, most of the studies that has happened in countries with a well-developed pre-hospital setup, where bystander CPR is provided, where the pre-hospital response time is very less, where many of the studies regarding termination of cardiac arrest has actually come in from Japan, where they even consider ECMO in the pre-hospital setup, and the patient is usually selected for ECMO based on that. So the survival from cardiac arrest actually dependent on how much time it takes to defibrillation and the return and the ROSC, and unless you have a primary reversible cause which is present, which is also identified in whenever the resuscitation is done. So what I would suggest is certain key questions that we need to ask ourselves would be, one, was the arrest observed or witnessed? What was the initial opening rhythm, if at all, over here? Because shockable usually has a much better outcome than systole. Whether the cause is cardiac versus non-cardiac, because always the survival in the cardiac group is always better in out of hospital cardiac arrest than in the non-cardiac group. The survival is better. The time required to initiate CPR, that's where the bystander CPR was initiated. How early was the shock given? Was there availability of an AED? And what is the time that was required to attain a ROSC? So these are certain questions that we need to ask ourselves before we consider termination. But anytime you are in doubt, continue it till you have more information regarding stopping the CPR. Over to you, Chanchal.
Okay, sir. Coming to our second question, I have already told, sir, regarding the bystander CPR. As the second case, we know that the patient was brought by ongoing CPR by the bystander. So whether it would be helpful to improve the survival rate of the victim, sir. And also regarding downtime to resuscitation time, also regarding the community responsibilities, to Vimal, sir. Sir, your voice is not audible, sir.
Hello, can you hear me now?
Hi, yes, sir. Yes, sir.
Okay, thank you for the question, Chanchal. I think Sachin sir is the best judge for this question. Downtime to resuscitation and community awareness, we're just done with a few events, and I think Sachin sir is right in the heart of an event right now as we speak, doing a large community awareness program. I think there is a huge responsibility for the chain of survival to be kept intact, and that responsibility starts off at the community level. And I don't think without the community's active participation, without the first responders and the community responders, citizen responders, I don't think we'd have the chain of survival leading to robust outcomes. If you look at the Resuscitation Council guidelines, they say that essentially for more than 20 minutes in the absence of a reversible cause with ongoing advanced efforts in itself, we might need to call off resuscitation. That means we just have a very small finite time window to start off resuscitation. And since the year that CPR external chest compression was introduced, I think we've seen that high quality chest compressions is a game changer. And if community can take part in high quality chest compression, that will definitely lead to strengthening of that link in that chain of survival, ultimately reflecting on outcomes. So community definitely has a huge responsibility. Compression alone, instead of doing the classical breath to chest component, can also lead to favorable outcomes if done in the right way. It's about teaching the skill, creating the awareness, and ensuring that there is participation from the community towards CPR. I think the no flow time and the low flow time concepts have been discussed earlier by Chandni ma'am and Anish sir. They've all discussed extensively on that aspect of no flow time. I think a no flow time, if there is a no flow time of 20 minutes or more, I think it's very difficult for that person to come back. It's very unlikely that resuscitation would be successful for good neurological outcomes, Chanjal. So the downtime to the mission should be to reduce the downtime to resuscitate the no flow time, reduce the no flow time, maybe make it as minimal as possible, and reduce the downtime to resuscitation, because at the end, after ROSC, neurological recovery, complete neurological recovery will depend on a very low downtime to resuscitation. I think Satya sir could add a little more on this.
Yeah, thanks, Vimal. So what? Again, it's interesting that you bring up the community and the bystander piece. So in 2005, in the US, they made it mandatory to teach school kids CPR, and that was included as a part of a curriculum from the 5th standard onwards. So there have been so many interventions that have actually influenced the survival post cardiac in cardiac arrest, including mechanical CPR devices, converting from ABCs to CAB. But it was bystander CPR. When they found that when this was made a mandatory part of the curriculum, suddenly we find improvement in the outcome for when out of hospital cardiac arrest. And so it's an interesting study. It came out, I think, in 2006 or 2007. And the reason they did the study was the moment this was implemented, there was a huge uptick in the survival post cardiac arrest. So and this is something that we see anytime we have our courses. When we teach resuscitation, lives are saved, but the impact of this is usually happening only in the in-hospital setup, and that's the reason there's so much of emphasis on improving the community piece, where that community link of early bystander CPR needs to be improved. And the best in case example is, if you need to have a cardiac arrest, the best place to have it is in Seattle in US, because within 100 meters you have access to somebody who knows CPR. And the reason is just not CPR, and access to an AED also. And so that indicates the importance of the community's piece, or the community aspect of bystander CPR. Back to you, Chanchal.
Okay, sir. Sir, coming to our last question, sir. What are the advances impacting decision-making process in resuscitation? The patient, whether the patient is getting a continuous shockable rhythm or non-shockable rhythm, whether it's affect the continuity of stopping CPR, sir. And also, is there any reason advances like defibrillation, newer technologies like POCUS or ECMO can help in this situation, sir? Coming to Vimal, sir.
Chanjal, thank you for the question. I think more importantly, in different cardiac arrests, you would have different newer modalities that you would use. For example, traumatic cardiac arrest, there is a lot of discussion on Riboa currently used in out-of-hospital traumatic cardiac arrest, where it fills a certain criteria. The other common point that is now discussed in all recent advanced cardiac arrest part is the eCPR, the ECMO-guided CPR. Sachin sir has discussed about the eCPR, even percolating into the pre-hospital setting in Japan. So eCPR is probably one of the entities which have shown a very good positive outcome across domains, not just in a pure poisoning case, but across domains in medical and traumatic emergencies. Revo is another thing. But going down to the basics, I think it's important to maintain the chest compression fraction, maintain the team dynamics, the basics, and then move towards the advanced ones. At the top of my head, I could think of these two for the traumatic cardiac arrest part. Defibrillation, there are different articles which are coming in specifically on double sequential defibrillation and other work. I think it has not yet percolated into guidelines yet. As a recommendation, we still follow the older guidelines for the defib part. Satyan sir?
Yeah, I would just like to add a bit on, since you mentioned double sequential defibrillation. So, see, as and when newer advances comes in, it is just an add-on or an adjunct to high-quality CPR. But what happens is when we start focusing too much on the newer advances, the emphasis should not shift from high-quality CPR to and that's one of the reasons why many of these newer techniques actually fails. Some of them are really helpful. Example is ETCO2. That just revolutionized, the quality of CPR. It revolutionized whether the patient has achieved ROSC. But at the same time, there is a tendency that when you find that the ETCO2, this is one example, the ETCO2 suddenly jumps up, you should not be stopping the compressions. You have to continue it till that entire cycle of 2 minutes before you check for whether there is ROSC. So these are certain nuances that you need to be very clear on. That's one. And the second thing is that regarding double sequential defibrillation, it looks very good as a theoretical concept. It has been basically been studied by the American Ambulance in the pre-hospital setup in selected patients, and that study itself had a lot of biases because their definition of resistant VF was when at the end of 5 shocks. And that's when they selected the patients for double sequential defibrillation. So if the team is highly trained, yes, it can be attempted as a rescue method for defibrillation in shockable rhythms. But what we need to understand is there is a physiological limit. Like you can't keep on increasing it. So the theory behind double sequential defibrillation is that with one shock, at least 90% of the myocardium should be depolarized, which does not happen. So you just give two simultaneous or back-to-back shocks. It's believed that 90% of the myocardium will get depolarized. And that will actually help in shifting from a shockable rhythm to a normal cardiac rhythm. But again, it's at the end of the day, it's just a cardiac muscle. It's a cell. So the number of sodium channels it has is limited. So just keeping on increasing the shock will not work. So there is a physiological threshold where the effect actually plateaus off and then it stops. So again, long story short, newer techniques are good if they are adjuncts to high quality CPR. Back to you, Chanchal.
Okay, sir. Thanks for your contribution, both Sachin sir and Vimal sir. So we are, as we are having a short of time, we are going to the other session. So we'll be getting back to you, sir. Thanks.
Thank you so much.
Thank you, Sachin sir and Vimal sir, for guiding us through this topic. Actually, as you know, these are all topics in which when to start resuscitation and when to stop resuscitation. It's not so easy task, and it's always a multidisciplinary approach. And the discussion need a lot of confounding factors and all. But I think when we hear this discussion, we know we have some knowledge to when to stop and when to start, when to start and when to stop resuscitation. So next, the role of focus and adjuncts in guiding out of hospital cardiac arrest resuscitation. Here we have the panelist Rajiv sir. He's the professor of the Department of Emergency Medicine at Jubilee Mission Medical College, Thrissur. Hope you are here, sir.
Yes,
Thank you, sir. Thank you for spending
Am I audible?
time here, sir. Next is Dr. Ranjit TP. He's my own senior at Calicut Medical College, and it's just a formality to invite you, sir.
Yeah. Am I audible?
Yeah, you are audible.
Okay, fine.
Okay, and our moderator is Mohammed Mustafa. He is a senior resident at the Department of Emergency Medicine at PKDIMS Institute of Medical Sciences. Over to you, Mustafa.
Thank you, Gil sir. I invite Dr. Ranjit sir and Dr. Rajiv sir for the discussion. Over to Ranjit sir. The role of focus.
So,
Sir,
1 minute, okay. Before the start, I would like to thank PKDIMS, Institute of Medical Science, as well as this one Akhil and Mustafa for inviting us all for this wonderful section. I think this is the need for the hour, the importance of cardiac arrest and its management. So what we have decided is that actually we have two topics. So we have divided the topics among myself and Ranjit. So Ranjit will be talking about the focus, the role of focus, and I will be talking about the various agents that can be used in cardiac arrest. Okay. Over to you.
Thank you, sir. Over to Ranjit sir. Is there any role for focus to be used in out-of-hospital cardiac arrest? Ranjit sir.
Okay. So before starting, let me thank Akhil and the whole team of PKDIMS for giving me this opportunity to talk along with this eminent panel and this such an expertise panel. And I feel really blessed to be a panelist along these people. So regarding the topic, so is there any role for the focus? So let us begin with what American Heart Association have to say on the utility of focus in cardiac arrest. So as Sachin, I'll be continuing what Sachin sir was saying in the last topic. Actually, we have a number of newer adjuncts, but the cornerstone is the high quality compressions. So regarding the statement that American Heart Association have to stay on using point of care ultrasonography in out of hospital cardiac arrest, I'll read out the statement that AHA is saying. So the latest recommendation on using of focus in cardiac arrest came in 2022 ILCOR treatment summary that came, and I'll read out that. Actually, this states that we suggest against the routine use of point of care ultrasound during CPR to diagnose the reversible causes of cardiac arrest. And we suggest that if focus can be performed by an experienced personnel without interrupting CPR, and it may be considered as an additional diagnostic tool when the clinical suspicion for reversible causes present. So this is exactly what Sachin sir was saying. So, and the recommendation here is weak recommendation with very low quality of evidence. So they are not saying it is a big no, but the thing is that it should not interrupt the high quality CPR. So the exact thing is the good practice statement that AHI is saying is that, so any deployment of focus during CPR, that should be considered and weighted against any interruption of CPR and misinterpretation of the sonographic findings. So the main thing is that there should be a good team to continue the high quality CPR. There should not be any interruptions. And the other thing is that there should not be any misinterpretation of the diagnostic findings that you get in the focus. So it is not a no, but you make sure that the teamwork is right. So that is the first thing that I have to say. Okay.
So focus do have a role. So Ranjit sir, what are the roles, and is there any protocol for that?
Okay,
are there any protocols?
Fine. So as we said before, the main role of focus is identifying the reversible causes, mainly the identifiable reversible causes of cardiac arrest. So that is the main role of focus. So I'll brush up on the protocols so that can help the residents here who have joined the panel discussion. So it all started with the earliest protocols that came was the FEEL and the FEAR protocol that actually used transesophageal echo to assess the cardiac activity during cardiac arrest. So the reversible causes like the cardiac tamponade and RV strain, that is the pulmonary embolism, was assessed in the first two protocols. That is the FEAR and FEEL protocol. And then the observation study that came for that, the protocol was for the FEEL protocol, and that found that there was alteration in the management in nearly 78% of the cases. So that was a landmark study that happened initially. So then came the integration of other parts. So initially the pulmonary part, that is the tension pneumothorax, was assessed in a protocol called COS protocol, and the abdomen part, the fast examination along with the tension pneumothorax, so that the hypovolemia can also be found out, was first used in a protocol called CASA examination, the cardiac arrest sonographic assessment, the CASA protocol. So this was the development of the protocols, and then we expanded that to looking at the IVCs. So then came the PEA protocol that discussed the pulmonary, the abdomen and epigastric, PEA, the all three, along with the cardiac, lung and the fast examination. So then came the PEA protocol and the POCUS CA protocol that integrated the DVT assessment also along with that. So different types of protocols came for evaluation to find out the reversible causes. And then we have the Sesame protocol that was suggested by our famous Laken's team, where initially the order was different. Initially they were looking for the extra cardiac causes first, and they were going from lungs, legs, belly, and then going to heart, so that the interruptions will be minimal. So different protocols, and then there is certain protocols like ECALS protocols. So there are different protocols for point of care ultrasonography. So I just mentioned a few of them because the residents can utilize those to study a bit more on the ultrasonography findings. So mainly that they were focusing on that the reversible causes, that is the 2H and the 5Ts that we can identify. So the 2H, mainly the hypoxia that can be assessed by the lung assessment, and then the hypovolemia part by looking at the FAST and the IVCs, and then the 3Ts mainly that they assessed was tamponade, tension pneumothorax, and the pulmonary thrombosis. So these were the reversible things that they were looking at the different protocols. Okay. And the other, then one more thing that that was important in the looking POCUS for the diagnostic part was for differentiating pseudo PE and PEA. So pseudo PEA means there is a myocardial electrical activity, and you can't feel a pulse, but when you assess the ultrasound, you get the cardiac activity. So that is a pseudo PEA. So that is a case of severe cardiogenic shock. So what the patient needs is a inotropic support. So and if it is a true PEA, you can there is no myocardial contractility. So so these were the things that POCUS can help in identifying and diagnosing the reversible causes.
Okay, sir. Sir, is there any role for POCUS in prognostication?
Okay, so that is a tricky question. So the landmark trial that came regarding the role of POCUS in prognosticating in out-of-hospital cardiac arrest was the recent trial that was published in 2016 by US study that incorporated nearly 1,000 patients. And what they found that they were assessing the cardiac contractility, the initial cardiac activity of when you do the first POCUS. Okay, so in that, if there was a cardiac activity, the chance for ROSC was nearly 51% compared to 14% when there is no cardiac activity, initial cardiac activity. And to survival to hospital discharge in patients with cardiac activity on ultrasonography, it was nearly 4%, but in patients with no cardiac activity, it is nearly 0.6%. So the initial cardiac activity, if that is present, that gives us a clue that we get a prediction that there is high chance of ROSC or not. But if there is, all of these are dynamic. The single cardiac activity present or not can't determine whether we can stop a resuscitation or not. So it's just that we can get an idea regarding the prognosis, but the decision regarding initiation or stopping the CPR should not be relying on just the cardiac activity part. Okay.
Okay, sir. Is there any limitations for using this POCUS?
So that was the first thing, the statement that we were discussing about, the limitations regarding using POCUS. So the prime role is that it should not interrupt the CPR, the high quality compressions. So it prolongs. So there have been different 2 to 3 observational studies that came that when you are using POCUS along with the resuscitation, the interruptions were a little higher than the other. So the main thing is the interruption should not be there. So that is the main challenge that we face. Then if there is a defibrillator pad attached, so the immediate acquisition will be difficult, or it is a stressful environment, so it will be very difficult to acquire a good window. So these are the challenges that we face. So the main thing that what we should do is the 4 phase of POCUS, how you integrate POCUS in cardiac arrest. That should be in 4 phases. So the first thing is the preparatory phase. So before the interruption, so the POCUS the examination will be during the interruptions for pulse checks, right? So the preparatory phases before that, the 20 seconds before the pulse check, you should prepare the probe in the chest and make sure that beginning with instructions for pulse check, the POCUS acquisition occurs. So that is the preparatory phase. And during the pulse check, when you get the window, you don't interpret the POCUS. You just record the clip that is available at that time. And when you resume the CPR, then you reassess the recorded clip and interpret that. And then the last 45 seconds before, after that you do on the intervention that is required. So that is the best way that you can tide over this, the limitations of doing the POCUS.
Thank you, sir. And any advantages of using transesophageal echo?
So that is also a tricky one. So the main advantage is that the interruptions will be minimal. When you are doing a transthoracic echo, you can do it only during the pulse check, and the pulse check may go prolonged. So the main advantage is that it can minimize the interruptions during CPR. And the other thing is that you can get real feedback, real-time feedback for CPR also. So if you are compressing the LV, or if you are compressing the LV, OT, or the aorta, the chance for survivals will be low. So you can reposition according to the where we are compressing. So that is the advantage of that. But comparing to TE, you can diagnose only the cardiac components of the reversible causes. And the other thing is, if you are going for an eCPR, so if there is a TE, that will guide us for putting the eCPR. So that is the advantages of TE over the transthoracic echo.
Thank you, Ranjit sir. We will be going to adjuncts next. That is, I invite Dr. Rajiv sir for that. Sir, what are the adjuncts, apart from the POCUS, what are the adjuncts that aid in resuscitation? Sir, can you please?
Okay. Am I here now? Yeah.
Yes.
So any additional tool that helps in the resuscitation is an adjunct. Okay. So in any case of the use of adjuncts, usually they improve the effectiveness as well as the outcome in many of the cases. So so while considering any cardiac arrest, we always tell about this chain of survival. Okay, in out of hospital cardiac arrest as well as the inside, but we are talking about outside hospital cardiac arrest. So the early recognition is always important in initiating a cardiac arrest. So even during the pre-hospital phase, the adjuncts can be used, like a community initiate to promote CPR implementations. So and a public access of the defibrillator. So as Sachin has already told, in some places where these are available, and if the people are aware of such a things, the early use of AED can have a great impact in the outcome of the patient. The use of mobile technologies has also been incorporated in newer guidelines since 2015, I think. And with that, we can initiate or call for help immediately if you are alone with the patient. And also, you can have, whenever you have a team, the use of cognitive aids like the checklist, if there is alarm, or any mobile applications, or mnemonics like the CAB and ABCD, like that, if it is available, the pre-hospital paramedics can utilize this to initiate CPR. And considering in hospital, or once we start doing the second phase, that is the early CPR, that is the compression, there are so many adjuncts or methods by which we can improve the quality of compression. So the most important factor that have a good outcome will be a very good cardiac compression fraction. So there can be feedback devices which can be used that can improve the quality of compression as well as the CCF, like the use of CPR meter or a metronome by which you can align with the rate. Okay, or when you can have an airway adjuncts like OP or NPA, that can improve the ventilation while doing a CPR. And the use of masks like pocket mask, BMV, if it is available, even during a BLS stage, you can improve the quality of CPR. And also the team coordination tools like mobile phone, if it is available, you can initiate, you can have more number of people to activate or to start or continue with the code. And okay, and even during the other phases, like during your compression and then following your rows, in each stage there are different agents that can be used, which can all help in the improvement of the outcome. Okay. So I suppose my okay. Right.
Sir, how does adjuncts help following ROSC, following attaining ROSC?
Okay. See the adjuncts. There are so many types that while considering about the ABCD, all aspects you can use adjuncts. So it start with and many of these we have, even though there are few studies that are available, but the class of recommendation is only moderate to severe, moderate to weak, and also the level of evidence is also not that much thing. But still, if you use supplemental oxygen during CPR, the chances is much better when compared when it is not being used. And the use of EtCO2 during your compression phase, it helps in a lot of things because it helps to know about the your quality of compression. It helps to know whether you have attained the ROSC in between, or even while intubation, it helps in it is 100% sensitive in detecting the localization or the confirmation of the tube position. And during this process, there are a few other adjuncts that can be used, like ABG or VBG, which has uncertain value in the prognostication. But there are a few studies that has been already been done. And one of the studies that we have done is the SWAP score, where we use, there are 4 different parameters that are there. That is the shockable, and then whether it is witness, and the age which is more than 60, and whether the pH less than 7. So one score for all. So the score of 0 and 1 has got a good prognosis, good neurological prognosis. The more the score, the worse. So the ABG or VBG can help in some of these in identifying some of these things. Okay, and during there are a few advanced techniques as well as devices that can also be used, like whether to intubate the patient while doing CPR, because intubation, even though it may be a risky at some situation, but if it is done by an expert and if it is done properly, probably you can improve the quality of compression by improving the CCF. So ET tube or supraglottic airway device, both can be used, but that depends upon the expertise. Both are equally good, and both can help in uninterrupted compression, which can have a better CCF. And then about the different devices, advanced devices that can be used are a few, like mechanical devices. There are 2 different types, and these mechanical devices helps in reviving this patient if the situation is not favorable for the rescuer to respond, or while transporting the patient, this mechanical CPR device, or if the patient is inside the theater undergoing what to say PCI, probably this mechanical device can be used in between. And also sometimes the eCPR can also be used. In some places it has been used, and as Sachin has told, in Japan, it is already been there with the pre-hospital paramedics, where in select patients with reversible causes, eCPR can also be used in between. Okay, and your question regarding the adjuncts following attaining of ROC. the ROAC is an important thing. You should not stop with ROAC because it is also there are a few other chain that is also following the ROAC, like post-operative, post ROAC stabilization as well as the recovery phase. The most important thing will be the hemodynamic support. Probably once the patient is admitted or during the when ROAC is being done or the patient is being transferred following ROAC, the management of or monitoring or the management of the hemodynamic status is very important, like the pulse, the BP, the SPO, the saturation. All these are very important following ROAC. And once the patient is intubated and put on a ventilator, probably you have to look for the rate, which has to be set at least 10 per minute, and you have to maintain PO2 between 92 and 98, as well as PCO2 has to be maintained between 35 and 45. And regarding the neuroprognostication, to have a better neurological outcome, you have to maintain with the targeted temperature management, where the temperature has to be maintained between 32 and 36 for at least 24 hours. That is also an adjunct, actually a different form of adjunct. And
neuroprognostication, we have another topic. Sir. Next, it's coming.
So I won't be discussing much on that. And also during following rows, we have to diagnose and treat the underlying cause also. So some of the things the ultrasound can help, and some of the time, because when it is a this out of hospital arrest, most of the time we don't know what's the diagnosis all about. But sometimes still with a clear-cut history and probably with the history with the patients or with the medical history that is may be available, at least some P's and T's can also be identified. PCI, Ribova are some of the other adjuncts when you have a diagnosis which has led to the cardiac arrest. And also sometimes for neuroprognostication, the CT that will be anyway again talking. And the critical management of patients is also very important, following like nutrition and following recovery also. The patient will be having physical, neurological, cognitive, emotional, and other social issues, which also has to be dealt with in a different way. So these are some of the adjuncts. And finally, how to improve the resuscitation performance as a whole. So the debriefing tools may be important, because that helps in even if not this patient, but the next patient who comes. So in all cases, we have to have a good debriefing tools so that all the rescuers are well versed with the different steps that are available. And also the data registry, which may also which can be a tool that can be used to have a overall view about the CPR status as well as the cardiac arrest status in our place. So overall, even though the adjuncts only helps, but the primary thing will always be you think about the different chain of survival. So in each step, remember that it's not just the airway, breathing, and other things. There are so many adjuncts that can be used right from the early diagnosis till the recovery phase. Thank you. Anything more?
Thank you, sir, for the wonderful discussion. Sir, as the time is low, we will move on to next discussion. Thank you, sir.
Thank you. Thank you.
Thank you, Rajesh sir and Ranjit sir, for this very good discussion. Actually, we know we have a lot of topics to discuss. That's why we can only rush through the topics. Most of the topics are actually, these topics can be given for a webinar. That's the duration of the topic regarding focus, regarding adjuncts. And we have a lot of doubts also. But the problem is we have 4 more topics remaining. Sorry, sir. We will again having a sessions with you guys in the coming webinar series. Thank you, sir. Thank you for spending your time with you, sir. Thank you. So next topic will be difference in traumatic cardiac arrest and special situations. And this topic will be discussed by none other than the assistant professor from the Apex Trauma Center, AIMS, New Delhi, Dr. Vinny Chandran. Sir, it was a nice meeting with you, sir, and it's your student only discussing with you, Dr. Ahmad Shaheen, who is a senior resident Department of Emergency Medicine. I think it will be going to a faculty-student discussion. So, sir, we have a lot of doubts in difference in traumatic cardiac arrest and other special situations. Over to you, Dr. Shaheen.
Thank you, Akhil sir. Welcome, Vinny sir, to the webinar. Okay, so we are moving on to the topic. As we all know, causes of traumatic cardiac arrest are different from causes of medical cardiac arrest, and mortality in terms of traumatic cardiac arrest are high. Now, survival from the traumatic cardiac arrest are improving now. So, our first discussion on reversible cause of traumatic cardiac arrest. Sir, please discuss about the reversible causes in traumatic cardiac arrest. Over to you, sir.
Yeah, hello. Thank you, Shahim. And thank you, Akhil, for that super introduction. I also thank the entire team for actually welcoming me for this webinar among the group of the panelists as a panelist. So, we'll start with I'll rush through, but I'll just start with a few basic things. So, as Dr. Shahim has already mentioned, the mortality in traumatic cardiac arrest is said to be low. But unless you have definite signs of death, it is always imperative that you start with resuscitation. So there are various statistics saying the mortality as high, the survival as low as 0.5% till 32%. So it's very the mortality rate is also not fixed. It's varying. So the arrest in trauma can be thought of as three types. One would be arrest secondary to injuries that are incompatible with life, like injury to a large vessel, injury to a direct injury to heart, or expulsion of brain. So those are unsurvivable injuries. That would be one. Second would be the reversible causes. So when we think of the HS&Ts in our normal ACLS cardiac arrest, the HS&Ts that would be usually be applicable here would be your hypoxia, your hypovolemia or hemorrhagic shock, your tension pneumothorax, and cardiac tamponade. So these four would be your reversible HS&Ts mainly in your trauma arrest. And the third category of group would be a patient who is having a medical cause of a cardiac arrest and having a secondary trauma, right? Like a driver having a sudden MI, seizure, then ramming onto another vehicle causing a trauma. So that can be also a cause of a traumatic cardiac arrest. So basically the HS&Ts or the reversible causes in trauma would be your hypoxia, hypovolemia, tension pneumothorax, and cardiac tamponade.
As we know, in terms of medical cardiac arrest, we have to prioritize early chest compression, early defibrillation. But what are the difference in priorities in initial management of traumatic cardiac arrest?
Okay. So traumatic cardiac arrest, there is an algorithm by European Resuscitation Council put out in 2021 on the traumatic cardiac arrest. So according to that, or what is practiced everywhere, it is when a patient comes in with trauma in cardiac arrest, first would be you will be stopping any kind of external bleed. I think Dr. Vimal has already discussed this. First priority would be to stop any kind of external bleed immediately. Put an IV line, start with fluids, bilateral ICD to remove any tension pneumothorax, tube parallelly, someone should secure the airway tube. And if you have expertise, if you have the equipments, if you have the environment, and if the time of arrest is less than 15 minutes, then we can think of resuscitative thoracotomy also. So resuscitative thoracotomy would actually help in relieving the tamponade, stop any active bleed in the aorta, cross clamping of aorta. You can also do a internal cardiac massage also. So resuscitative thoracotomy would be another thing that needs to be considered in a traumatic cardiac arrest. So our major, as the question goes, the initial management priorities, it would be, so CPR would be started along with this. So there is no doubt in that CPR would be started along with this. But along with that, we'll also consider stopping bleeding, securing airway side by side, bilateral ICDs, starting fluids and blood and products, and also resuscitative thoracotomy. So I'll also just add a few bits and points regarding traumatic cardiac arrest, the difference from a medical cardiac arrest. So as you know, medical cardiac arrest will be more on the most important thing in that would be CPR. So in according to European Resuscitation Council, they have a word saying don't pump an empty heart. So you don't pump an empty heart if the patient is exsanguinated. Then the initial management would be to start give him fluids and then side by side give CPR. So CPR is still important, but these things also should be thought of, like fluid resuscitation or blood resuscitation. You are relieving tamponade and tension pneumothorax. So the reversible causes should also be given equal priority as CPR. That is what they say. And also your the significance of adrenaline is controversial. Significance of adrenaline, it has a conflicting evidence. And POCUS has already, Dr. Ranjit has already said, according to American Heart Association, they are saying not to start or not to do a routine POCUS because that might delay your CPR. But according to European Resuscitation Council, and that too specifically in trauma, they are asking to do a sonography if you can't find out a reversible cause of arrest. So it is also a conflicting thing. So in the routine ACLS practice in a medical cause, the same things applies to trauma also, but the highlight or the importance would be a bit different and would be more focusing on the reversible causes. Yeah.
So next we are discussing about the indication to stop resuscitation in traumatic cardiacs. Also, we have to discuss when to withhold resuscitation in traumatic cardiac arrest as well.
Okay, so that would be two things. One is when you should not start a CPR or when you should not start a resuscitation. So that would be when you have a patient who has already injuries that are incompatible with survival. That is like decapitation, decorporation. If you have a brain injury with actively brain is out of the head, and if you have a large vessel injury in the thorax, in aorta. So in those conditions, and if you don't have any signs of life in the preceding 15 minutes, so if there is arrest for the past 15 minutes, if there is no sign of life in the past 15 minutes, then you need not start resuscitation. And you can stop resuscitation when, as I already discussed, when you address all the reversible causes, like you start with fluids, you do a thoracotomy, you relieve a tension pneumothorax and tamponade if it is there, you give flow, you secure the airway, so you are addressing the reversible H's and T's, and still if you are not getting a ROSC, then you can think of stopping your resuscitative efforts. So you may not start if there are injuries that are incompatible with life and there is no signs of life in the preceding 15 minutes, and you can stop it if there is no ROSC even after you address the reversible causes. You can think of stopping the CPR or stopping the resuscitation.
Okay, sir. We are moving to the special situation in out-hospital cardiac arrest due to drowning. What are the major differences in drowning victims?
Okay, so drowning would be the usual treatment guidelines is all the same, but drowning, as we already know, hypoxia is the cause of arrest there. Mostly hypoxia is the cause of arrest there, and so according to the AHA ACLS guidelines, that is one area where you actually give more importance to breathing than CPR. So when you take the patient out of water, the patient is in arrest, you start giving 2 breaths and then you start with CPR. So open the airway, check breathing, if none, start with 2 rescue breaths and then start with CPR. So that is what AHA says. So this is one condition where you give importance to breathing and then you start with CPR. So there is also been discussion regarding in water resuscitation. So if you have expertise, if it is safe, then they are even asking to start resuscitation in water, in the water while the patient is in the water also. And you might have doubt that the patient has had a drowning incident and is brought to you. Should you stabilize the C-spine? And then if you are intubating, should you stabilize the C-spine and be more careful of that? So it is saying that the injury to C-spine secondary to drowning, the probability is very less. It is less than 0.7%. So routine C-spine stabilization is not required unless you have a definite history, like patient has died from a height and then he has drowned, then the diving itself could have caused a C-spine injury, then yes, you will have to stabilize. But in other cases, routine stabilization is not required, and no regular clearing of the airway is also required, because most of the water that entered would be reabsorbed to the central circulation, so you do not require regular clearing also. So your arrest protocol remains the same. Only difference is you give a bit more importance to breathing and ventilation. That's all.
Thank you, sir, for your valuable time.
Yeah, thank you for having me. Yeah,
thank you, sir. Actually, I think, sir, traumatic cardiac arrest have some more protocols when compared to the other scenarios. I think when we discuss these areas, where we get more guidelines will be traumatic cardiac arrest. Am I right, sir?
Traumatic cardiac arrest, they do have guidelines, but the put out guidelines or from the bodies that are put out, the definite guidelines is from the European resuscitation guidelines, and most of them, there are East and West guidelines for resuscitative thoracotomy. There are different guidelines in East and West guidelines are there. So regarding resuscitative thoracotomy, you get many guidelines, but traumatic cardiac arrest, they do have, but it almost boils down to the same. I think there is not much of a difference, and it is very vague also. It is not a definite thing, because the research, and as we all know, doing a study in a cardiac arrest is very difficult. So the evidence is evolving, so we might have a better thing in the future.
Also, sir, Dr. Sanjeev sir also agreed initially for our topic, but due to some unforeseen circumstances, he can't do it actually. But we will be doing another session on traumatic cardiac arrest with you, both of you guys, sir. Very much.
Sure. It will be a pleasure.
Thank you, sir. Thanks, sir. Thanks a lot. So the next topic we'll be dealing with out of hospital cardiac arrest in pediatric age group. Is there any difference when compared to adult scenarios? So this panelist will be Dr. Midun Mohan. He's my mentor actually. He's the head of the department and senior consultant, Department of Emergency Medicine at Cooperative Hospital. Dr. Midun Murali Krishna, assistant professor and senior consultant, Department of Emergency Medicine at Pushpagiri Medical College. And Dr. Arjun James is the assistant professor and senior consultant and Department of Emergency Medicine at Pushpagiri Medical College. And our moderator will be Dr. Mohammad Najidil Safwan. He is the senior resident at Avron Institute at PKDIMS Institute of Medical Science, Kerala. So over to you, Dr. Najidil.
Thank you, sir. So we will be discussing regarding the topic of out-of-hospital cardiac arrest in pediatric age group. So we will be covering the causes, risk factors, ethical consideration, everything. So due to time restraints, we have framed 4 questions here. So we will be directly going to question. So Dr. Midun Murali, sir. So what are the common causes and risk factors for pediatric cardiac arrest outside hospital, and how do they influence the resuscitation decisions?
Okay. First of all, thank you, PKDIMS Institute and the Emergency Department there for this opportunity, and I would like to thank Dr. Akhil also for organizing, and his colleagues, everyone, for organizing such a wonderful seminar. And my PG Mustafa, Dr. Mustafa is also there, so I was very excited when this opportunity crept upon me. So, and I'm not wasting any time now. We'll just get into it because we are short of time. So the first question is why pediatric cardiac arrest has occurred. So definitely, when compared to adults, the etiology is very much different in children. So most often, as we know, the main culprit is the respiratory system, a respiratory failure, especially hypoxia, is attributed as the main cause of recent precipitating cardiac arrest. Then hypoxia, as we know more, the reasons could be any respiratory failure and respiratory distress. So respiratory distress failure, this could be because of any upper airway pathologies, lower airway pathologies, all those things, crew, anaphylaxis, foreign body, then lower airway, you have asthma, bronchiolitis, all those things. This respiratory pathologies are the predominant culprits when it comes to cardiac arrest occurring in children. Then the next common cause, when we talk about the reversible causes of cardiac arrest, like that itself, the second cause comes as hypovolemia. So that there could be septic shock. So shock invariably if uncorrected, which leads to cardiac arrest scenario. Then another important scenario which we need to think about is dysrhythmias in children. So why is it important? It's important. It's very rare when it's not that common when you think about it. But the importance of that thing comes in the reversibility, the final outcome of this whole endeavor, which we may venture into. We'll be the first one who will be making the decision to start the resuscitation or not. And so, if there is any family history of any cardiac disorders, dysrhythmias in family, or any noted such etiology which reversible good cause, we should definitely venture into a resuscitation endeavor, because that may ultimately result in a good neurological outcome and the child going home.
Okay. Thank you, sir. Midun Mohan sir, Dr. Midun Mohan sir, are you here? Hello.
Yes,
Sir, do you want to add on anything, sir, regarding this?
Respiratory. First of all, thank you for inviting me as a panelist here. Just like Midun said, respiratory failure is one of the most common causes. Apart from that, trauma. And trauma is, I think it is the most common cause for out-of-hospital cardiac arrest here. All right. Then along with that, there is drowning. Okay, we hear drowning cases every day in the newspaper and all. And respiratory failure as a cause of out-of-hospital cardiac arrest in our setting is fortunately much less. It's mainly for in-hospital cardiac arrest. But again, these are the common causes. And one more thing to add is the age of the child actually matters. If you look at it, the survival to hospital discharge for out-of-hospital cardiac arrest in pediatrics is almost as same as that of adults, around 11%. But if you look at it age-wise, adolescents have a better survival of around 20%. And the survival actually decreases as the age goes down. All right. So for infants, the survival is very minimal, around 4 or 5%. So age is also a very important factor. All right. That's it.
Okay. Thank you, sir. So, Arjun sir, what interventions have been found to be the most effective in pediatric out-of-hospital cardiac arrest, and how can we compare those used to in adults?
Okay, thank you, Akhil and team, the most dynamic emergency medicine team in Kerala now. We're running a very good academic emergency medicine department. Thank you for organizing this webinar. And so coming back to the question, so already Midunatan has told that the trends, what we see in the out-of-hospital survival rate when it comes to the adult, it is not the same that you see in the children. The overall survival rate is less than 10%, and out of that, most of them has an unfavorable neurological outcome. So there is something to be done to improve the survival. So when you divide the what are the interventions which we can do to improve the survival, there are two groups, that is a modifiable and a non-modifiable. In modifiable, obviously Midunatan told that the older age, if you see the first rhythm as a shockable rhythm, and if you see that it is a witnessed cardiac arrest, these are all the non-modifiable interventions that can improve the survival of out-of-hospital cardiac arrest. When it comes to the modifiable factors, one and the foremost thing is obviously the bystander CPR. If you see that the bystander has done a CPR which incorporates the correct depth and the compression rate, that can definitely improve the survival rate. The second and most important thing, which is not that common in our area, is the early arrival by the EMS team to the scene of out-of-hospital cardiac arrest. When you have an early arrival by the EMS team, they could do an early defibrillation, they could put an early IV or an IO access, they could do an early defibrillation. These are all the things which can improve these are all the interventions that can improve the survival benefit. And Dr. Nitin Murali has already told that one of the most important cause of cardiac arrest is hypoxia or asphyxia. So you need to start the patient on oxygen because your lungs are depleted with oxygen. And telling that you need to start the oxygen doesn't mean that you need to put an advanced airway. When you look in the literature, the pre-hospital advanced airway, no much effect to the survival benefit. So so maintaining the chain of survival, that is early bystander intervention, early chest compression, early defibrillation, early medications, that is the intervention that we need to do to improve the out of hospital cardiac arrest. Thank you.
Okay, thank you, sir. So, Dr. Nitin Murali, sir. Can you discuss regarding the unique ethical consideration in deciding whether to resuscitate pediatric patients compared to adults, especially concerning the quality of life and long-term outcomes?
So all of us would remember that encounter which we had with a pediatric arrest happening in IED. So most of those experiences are unforgettable. It is a very emotional, tense situation, and that decision to resuscitate or not, often I don't think there would be a thought. Invariably, the European guidelines, they had the protocol is once the question of resuscitation doesn't come, because once the child comes in, resuscitation invariably will be started. So and the one good dictum by which we can go is, as an ED physician, we can ensure that we run the code correctly to ensure the survival of the child. The question of survivability of a child who undergoes resuscitation are dependent on an umpteen number of factors, as Dr. Arjun already said. So early resuscitation, the best outcome is if the child, even though has a out of hospital cardiac arrest, the ROSC was attained before the child reached the hospital. If that is there, the child would have very good neurological outcome. And out of the total cardiac arrest, only around 3% will have a good neurological outcome post discharge. And a child which achieves ROSC in ED and survives 30 days and gets discharged, around 50% of those children would have good neurological outcome. That's what the resuscitation guidelines, resuscitation journal guidelines, which says. Then a notable trial which in this pediatric survival post cardiac out of hospital cardiac arrest is a TAPCA trial, which studied multiple factors which improved the good neurological, especially therapeutic hypothermia in pediatric population out of hospital cardiac arrest. And in those also, certain factors, as Dr. Arjun already discussed, early bystander CPR, a shockable rhythm which was defibrillated early, especially they're talking about bystander defibrillation also. All these things contribute to a good survival. So what we can take out of this whole discussion when it comes to whether to resuscitate or not a child who comes into the ED, definitely we should resuscitate, I think, because of the lot of emotional and the parental decision, parental question, dilemmas and all that. And the main factors which the next decision which comes into place, how long to resuscitate. So that would depend upon what was the etiology or what led the child into a cardiac arrest. Okay,
sir. Midun sir, do you want to add on anything, sir?
Very well put by Dr. Mithun there. The ethical issue, whether let's do a reality check here. Of course, we are going to start with station for pediatric out of hospital cardiac arrest unless there are evident unsalvageable injuries seen initially itself. All right, so we'll be starting the resuscitation. And regarding the emotional part, this is actually, even though we can identify that it might end up in a futile effort over a few minutes time, because we need to get the history of the downtime, the cause for possible cardiac arrest, the possible cause of cardiac arrest, then the underlying comorbidities of the child. It will take some time. So ongoing resuscitation will be there. During this time, we will be getting the history, if all records are available, we will be going through that. And only based on that, we will be taking a decision whether to continue resuscitation or not. Plus, this is a time to buy us. This is mainly to buy us time to prepare ourselves as well as prepare the caretakers for us to break the bad news. Okay, we need to prepare them adequately. All right. So this is a very important concern because proper grievance is also a major concern for us, not just facts whether to resuscitate or not. Emotional concerns, the cultural background, the education background, all has to be taken into concern. So this resuscitation time actually is buying us time to prepare the parents for accepting the bad news here. All right. Arjun, anything?
Yes, it's fine.
So, Arjun sir, how does involving families in resuscitation decision differ between pediatric and adult cases? And what role do parental preferences play in pediatric resuscitation?
So it's a very high controversial topic. So to include the family presence, we have a terminology even like FPDR, that is family presence during resuscitation. So when it goes to the evidences, what are the evidences? Evidence-based medicine tells that there is a growing tendency to value the presence of family or caregivers in resuscitation. So that means that if the family can be given the option, so if they want to see or if they want to be presented during resuscitation, if they want, they can be allowed. So the benefits is that we get a better coping or adjustment or an acceptance regarding the child survival rate. And second thing that they will see the team effort, how much effort the resuscitation team has done for this patient, and coping with the death, it will be a bit easy for us. But having said that, you cannot implement this on the very next day, because we are all emergency physicians dealing with adult emergencies. You can think about a situation where when we are dealing with a pediatric cardiac arrest, we will be in a very high mental demand. See, I will be calculating the age-based doses, calculating the age-based defibrillation doses, the pediatric specific guidelines, and I will be dealing with or playing with the small size equipments and emotional stresses. So when we are undergoing a high mental stress, and we see that a family member is also there, that will definitely increase our stress and intimidate. So in order to implement this, first of all, we need to have an healthcare training, so that what is to be done, what is to be taken back to the relatives, what things we should speak to the family members. So throughout the process, how we can guide them. So that should be there. Before implementing these things in our scenario, the most important thing is that our healthcare trainer should be trained.
Okay, sir. Thank you, sir. So, Midun sir, Dr. Midun,
Midhunetan can add something.
No, everything is fine regarding the. We are usually very good at breaking the bad news, even though because we are much more culturally oriented and emotionally, we are also much more attached to the public. All right. The important thing that is challenging for us during the resuscitation time, I think, is the lack of enough practice. Okay, Agil just said that he's getting around 26 to 30 adult out of hospital cardiac arrest patients, but I wonder how many cases of pediatric out of hospital cardiac arrest that you guys are getting. It's very less. I think in last 1 year I had only one case of out of hospital pediatric cardiac arrest. So preparation is very important here when we are managing such less frequent conditions. Okay, so simple things matter, like getting the IV line, or if IV access is not possible, going for the IO access. Your staff should be trained for all these things. So simulation-based learning is very important. See, when I practice, one of the important things that everyone missed was that taking off the adult paddles of the defibrillator, so that you can use the pediatric paddles. So such simple things will be missing in highly stressful situations. So more and more practice of managing cardiac arrest is definitely required. Simulation-based learning is the way to go.
Okay, thank you, sir.
Thank you, sir. Actually, this pediatric resuscitation is always a nightmare for us ED physicians. As you already told, we had a out-of-hospital traumatic cardiac arrest 2 days before. The child didn't survive actually, but it's still breaking bad, and all these things are actually very difficult for us. And maybe due to the number of cases and all, we are not dealing so much cases as we deal with adult cardiac arrest. Pediatric support is also very much essential in such situations. We always emphasize on that. Thank you.
Having a dedicated counseling room is very important.
Yes, sure, sir.
Yes,
Sure.
definitely.
Thank you, sir. Thank you, sir, for this wonderful session from pediatric cardiac arrest. And I think we can go to the next topic. We'll be having a pediatric cardiac arrest session coming in the coming webinar sessions also. Thank you, sir.
Thank you for the opportunity, and I wish you guys all the very best.
Thank you, sir. Thank you.
Thank you. Thank you. All the best.
Thank you. Coming to the next session. So until these sessions, we are having our emergency physicians, and also even though we had senior faculties like Chandri Madam, Rajiv sir, and all, now we'll be going to the next scenario: neurological recovery in out-of-hospital cardiac arrest victims. So I'm a little bit afraid because I am going to deal on big professors here. So our panelist one will be our own Andrew sir. He's the principal and professor of medicine of our own institute at PKDIMS Institute of Medical Science, and Dr. P.C. Gilwas. He's the professor emeritus of neurology at Jubilee Mission Medical College. Sir, both of you are here.
Thank you. Am I audible?
Sure, sir. You are audible, sir.
Thank you.
Yes, sir. Andrew sir, can you hear me, sir?
I can hear.
Okay, sir. Sir, as ED physicians, we are expecting a lot from you, but as you know, sir, we don't have much time because we are discussing these lot of topics with a lot of faculties, but still we need much more points from the neurological aspects, because after resuscitation, when you come to the neuroprognostication, that is very much good. We can't give a patient within coma to the bystanders. We can, the entire resuscitation part ends only when we hand over the patient with a good neuroprognostication to the bystanders. So, sir, can I discuss these points with you, sir? So, what are the key factors considered in the neuroprognostication? That is the immediate post-resuscitative measures to increase neurological prognosis, and timing regarding neuroprognostication, and imaging modalities to be considered. Andrew, sir?
So, even though return of circulation is the most important point, the emergency physician is concerned. For the prognosis, how we can prevent neurological injury is the most important. Because we know that in the out-of-hospital cardiac arrest, only 10% survives. And among the 10%, 50% is left with a significant neurological deficit. So it is very important to have a neuroprotection. So what we can do? The evidences are class 3 recommendations only. So the most important thing is we should have a comprehensive medical care of the patient, prevent the cerebral edema, acidosis, dehydration, electrolyte imbalance. So that is a adequate protection of the patient's circulation, so that further ischemia and injury can be prevented. That is the first thing. Second, there are certain medications which are recommended as class C. Evidence is not very much, and of which the most important is the temperature control, TTN. So some people recommend, or American Academy of Neurology 2017 and 2020 also, they have said it is useful. So the targeted temperature therapy maintain 32 to 34 degrees during the as early as possible, and 24 hours is said to improve the. But the problem is, in most of the places, there are not much facilities for this. Only external cooling is most often available. That is the problem with the cooling. The IV cooling, etc., is difficult. And many studies have shown that there are a lot of complications arising because of this cooling also. So many patients can develop hyper-electrolyte imbalance, arrhythmia, infection, etc. So that is the role of TTN. Dr. Gilwas will tell about this later. Next is the certain drugs. One is the coenzyme Q. Again, it is evidence is lacking. Second is edaravone. Again, many studies have shown that Following a cardiac arrest, there is free radical formation because within 3 to 5 minutes, the ATP store and production is stopped, the sodium potassium pump fails, and there is calcium entry into the cells, glutamate comes. So there are and free radicals are there and inflammation of course. So giving certain drugs may be beneficial. Second is coenzyme 2. Again, evidence is less. Steroids is also not a recommended thing. And I think Dr. Spiller sir will tell few more words regarding this TTM, temperature management.
Now, at the outset, let me, am I audible and clear?
Yes, audible.
At the outset, let me just say one thing. The topic itself, to resuscitate or not, an out-of-hospital cardiac arrest, is unthinkable. Because this is going to be tackled in the ED. The question of prognostication is going to come in the ICUs. So I do not think an ED physician can ever afford not to resuscitate unless there are definite, clear DNR orders. Except for that one situation, I think it is unsafe not to resuscitate a patient who's brought with an out-of-hospital cardiac arrest. The next thing is, why is prognostication important? It's important just for one huge reason. It helps in the conversation with the anxious relations and caregivers. That's the main thing. And if we can reliably predict outcomes, then it helps in planning and the future care of this patient, and perhaps avoid futile interventions. Like sending a patient for an MRI and then waiting until the MRI machine is free. You can avoid all those things because you're going to lose the patient anyway. Above all, if you have evidence-based data, then it will avoid what we call self-fulfilling prophecies. Typically, when a physician sees a patient and feels, oh, he won't survive, what do? Our entire tone goes down. The entire staff believe you, and that patient gets less care. Therefore, this self-fulfilling prophecies can be avoided if we have scientific data to back up our prognostication. Now, an excessively pessimistic prognostication can lead to premature withdrawal of life support systems. And remember, in almost all these cardiac arrest patients, the commonest cause of death is withdrawal of life support systems. Now, when does we'll now go on to the next thing about the timing regarding neuroprognostication. Now, on admission, appearances can be deceptive. You have an immobile patient, no response to pain, on a ventilator, maybe sedated. Now, all this is happening at a different time. And a sedated patient, now this can paint a very, very bleak picture. Therefore, it's very important to have sequential meetings with the family. Now, all this really is aimed more at the family and the patient's future. We have one meeting on admission where we convey the actual scenario as it is. The next we have is usually after about 24 hours. Now, this is talking about prognosis. We can talk to the family as often as they want. This is the most important thing. You talk to them as often as you want. But regarding prognosis, we do the assessments after 24 hours. And most importantly, it is well accepted now that we do this after 72 hours. Now, this helps the family to process the information that we have given them. It's not just bombarding them with a huge lot of information and they take it home. Besides, these prognostic tests have specific time windows in which they reveal the most information. Therefore, we need to use these time windows. And Andrews, anything you like to say on this?
Regarding the prognostication, I think, as a research, too early and too late should be avoided. That is the first thing. So usually it is always better to advise regarding prognostication after 72 hours. And again, overemphasis is given for investigations. So the basic, when 30 or 40 years back when we were students, at that time, prognostication was by pupil, corneal reflex, gag reflex, and the motor response to pain and presence of myoclonus. I think personally, still this holds true. Even though we have got a lot of investigations, we mainly rely on these basic clinical examination. But the problem is the proper application of this test. How we are doing the corneal reflex, how we are doing the pupillary reflex, how we are doing the gag reflex, which is very important. After 90 hours, absence of pupil, the chance of recovery is almost 100%. After 72 hours, if it is absent, is almost a very high chance that the patient will not recover. So, many times we use a torch which has got no light or no battery is there. So, adequate light reflex testing is very important. And again, think what are the medications patient has been on. Suppose patient has been given atropine, it can interfere. So, at that time, you should check for the corneal reflex. Again, doing the corneal reflex, many of us are in the habit of doing a conjunctival reflex than a corneal reflex. So, see that we are doing properly a corneal reflex or gag reflex also, but somebody is already indicated it has got no role. Third is the motor response. Give adequate pain and see whether the patient is responding. A scale less than 3, that is motor response, there is no withdrawal or flexion response or nothing is there. After 72 hours, the chance of recovery is very unlikely. Then the presence of myoclonus. Myoclonus can be of two types. That one occurs in the earliest part of myoclonic epilepsy, and second is the late myoclonus. A patient who is unconscious getting status myoclonus, again the prognosis is very bad. But reversely, a patient has a Lance-Adams syndrome, that is a patient who has recovered or patient is conscious with a stimulus developing a myoclonus, the prognosis is far better. So I again still recommend that we should have the clinical examination, that should be a serial examination, and have an early CT rather than MRI, because early CT will find out, suppose there is a subdural hematoma or a treatable condition is there, then within 48 hours you can have a repeat CT. And if the CT is showing abnormality, I personally feel there is no need of an MRI. And if the CT is fairly normal, and you do an MRI within 7 days. Too late an MRI will not be useful. 2 to 7 days we can have an MRI and look for structural changes. Over to you, sir.
So it's now recommended that we defer neurological prognosis at least 72 hours following return of spontaneous circulation in patients who are treated with therapeutic hypothermia. If they have been treated with therapeutic hypothermia, then we wait for 72 hours after that has been stopped. So I mean, a lot of things change when there is hypothermia.
Sir, one thing we usually have doubt is when the patient, most of the patients, even though they attend ROSC and they have a minimal neurological status like a GCS of E2, V2, M5, most of them will be discharged on this tracheostomy and all. What is the long-term survival chance of these patients, and will they improve their neurological status in the future, sir? First, is there any hope for them?
No, actually, if they are discharged, if you're able to discharge them, they probably are going to improve over time. At 3 months, they are going to do very well. If you're able to discharge them. The problem arises when you cannot discharge them safely. That's really the problem. Now, myoclonic jerks are often seen in the post-hypoxic patients. Any hypoxic ischemic encephalopathy has myoclonic jerks. But now, just these few jerks occurring should not really worry you. But when these jerks last for more than 30 minutes, then you call it a myoclonic status. That is going to be really, really worrying, right? Because it's quite different from the thing which comes much later, maybe days or a week later, which like Professor Andrews said, is your Lance-Adams syndrome. Well, this is a very typical syndrome, startle-induced myoclonus. They hear noise and then they are all shaking. Something falling in the ward and they are shaking. They try to get up and they are shaking. This is Lance-Adams syndrome. This is a pretty benign condition. I've had patients over months and then they suddenly get better. So this is Lance-Adams syndrome. Actually, a very typical thing there is when you get focal epileptiform activity at the vertex. This is the defining feature of Lance-Adams syndrome. And it responds very well to benzodiazepines. It responds very well to even sodium valproate. Now, when you were we are now taking a CT scan. Now, hypoxic ischemic injury gives rise to cytotoxic edema. Classically, if this occurs, this will be a loss of the gray-white differentiation on the CT scan. Like Professor Andrew said, the best thing is a CT scan. Number one, because it is easily available. It can take your ventilator. The MRI, you require a MRI compatible ventilator, which is not available at this point of time in Thrissur. So I think we need, and it's a big problem putting in a patient for over half an hour inside a tube. We are not certain as to what's going on inside. So now, if you see this pattern of loss of gray-white interface diffusely across vascular territories, you're dealing with a diffuse hypoxic injury, and this is best studied at about 48 to 72 hours. The outcome is supposed to be bad, although the recommendation is weak. In the MRI, we have what is called a restricted diffusion. You look at the diffusion weight of the images, and you see a similar pattern where it doesn't confine to one territory. It involves both the anterior circulation and the posterior circulation. It involves the gray cortex and the deep gray. When it is involved like that, then we know we have a bad prognosis. The next investigation which I must talk about is the EEG. Now, EEG we would also use in myoclonus to confirm it is indeed a myoclonus and not some movement which the nurse reported. Now, when you have a suppressed EEG, now by suppressed we mean an amplitude of less than 10 microvolts, or you have a burst suppression, like you have a burst and then a flat EEG. Now, if this is occurring 72 hours after ROSC in a non-sedated patient, that is ominous. It is a moderately reliable sign of a poor outcome. And then finally, we have one more test, which is the SSEP. Now here, we stimulate on the median nerve and pick up over the somatosensory cortex. The big advantage of this test is, and we'll look for what is called the N20. It's a positive wave, it's a negative wave which occurs at 20 milliseconds. The advantage here is that it can be done even in a sedated patient. Hypothermia does vitiate it, but sedation does not. So you can do this even in a sedated patient. And on the contrary, a good SSEP, a good N20 response predicts a good outcome. So that's a good point, a point which tells you this patient may have a good outcome. Regarding the drugs we commonly use, see, edema is the most ominous, threatening thing in a patient who has had a cardiac arrest. And even more, as the cells die, they release things like inflammatory markers, leukotrienes, cytokines, etc., which make the edema worse. One very useful thing which we often use is high-dose steroids. We always give it, I think, is high-dose steroids, keeping the patient well hydrated, but not overhydrated, is extremely important. So I think steroids are very commonly used. Anticonvulsants, we often use them even prophylactically. The moment we see an edematous brain, we expect that brain to convulse the moment it's left alone. So we often give even prophylactic anticonvulsants. Then there are drugs which we use more out of hope than conviction. There are drugs like that, like your citicoline, your paracetam. These are drugs which we use more out of hope than conviction. There are not much evidence regarding them, but we use them in hope.
Thank you, sir. Thank you, sir. Actually, we discussed about a lot about drugs and screening modalities. So, Andrew, sir, any more to add on?
One more, your last question, delayed post-hypoxic leukoencephalopathy. I will compare it like the osmotic demyelination. There is a patient with hyponatremia. You correct the sodium, the patient improves. Later, patient goes into problem. Same way, a hypoxic patient after recovery, that is, they may regain consciousness. Then they gradually become delirious. They become abnormal. They can have hallucinations. So behavioral problems, motor problems. That is called the delayed hypoxic leukoencephalopathy. So this can be diagnosed by taking an MRI where the U fibers are affected. That is the delayed hypoxic leukoencephalopathy. There are certain advice regarding the prevention, that is avoiding too much of activity by the patient during the immediate recovery period is said to reduce the incidence of hypoxic leukoencephalopathy. The problem is we can't predict who is going to develop it. Regarding the investigation, one more thing is the neuron-specific inhalates. That is said to be useful, but again, practical usefulness is mainly our clinical examination. That is what I would like to stress. You look at the pupillary reflex, corneal reflex, Geiger reflex, the motor response, myoclonus. And the
Sure,
facilities
sir.
are there, you go for an EEG. That again, lot of confounders, the electrical artifacts, everything is there. Interpretation is in person dependent.
Definitely, sir. Even though much of the newer guidelines are focused on these newer modalities of imaging and all, still we need these kinds of clinical examination to be relied upon for prognosticating these patients, sir. Thank you, sir. Actually, we need to go to the next topic. That's why we are stopping here. Am I audible, sir?
Oh.
Absolutely. Thank you.
Thank you, sir. Thank you, Professor Gilva, sir, for giving a little bit of time in your hectic schedule with us. And
Oh,
also,
thank you for having me. Thank you.
Thank you, Andrew, sir. Andrew, sir, actually, he was the one who was behind this webinar. He was the one who suggested to conduct us this webinar. Thank you, sir. Thank you pointing out these points and all. We will definitely having you on the next webinar series for the neuroprognostication, because as ED physicians, we are all not at all aware of both of many facts about this. Thank you, sir. We will be going to the next topic. Thank you for joining us, sir.
Thank you.
So next topic will be end of life care and emergency department. So we have left with two topics: end of life care and emergency department, and medical legal issues. Medical legal issues will be dealt by our retired JDM is Rayumari madam, and now the end of life care and emergency department. Here we have one panelist, Dr. Venugopal sir, but unfortunately he is stuck with some technical issues. That's why he can't join. And next panelist will be our own Dr. Nirmal Peter Abraham. It's coming home feeling with when discussed with him. He's the senior consultant in the emergency medicine department at ICRA International Hospital and Research Center. And the moderator will be Dr. Mohammed Jassin. He's the senior resident in the emergency medicine department at our own institute at PKDIMS Institute of Medical Science. Over to Mohammed.
Hello, doctor.
Hello, sir. Can you hear?
Yeah, sure.
Good evening.
Right?
Yeah, yes, sir. Moving to the second last topic for the day. Unfortunately, we couldn't have Venugopal sir on the platform today. Anyway, we have Nirmal sir. Sir, like unlike other patients in the ED, most of the times in ED physicians are aggressive regarding the management of the patient. But when it comes to the patients at the end of life, they might not be happy with such aggressive management. Most of the time, we may not know why the patient is there in the ED, because they are at the end of the life. So the patient priorities or what they want from the ED is unlike other patients coming to the ED. Maybe they may want to spend some time with the relatives, or they may come with, like suppose the patient is at some terminal illness, they may need some pain relief or symptom control. So we'll be discussing briefly regarding these things. So, sir, what is end of life, or who will take the decision of end of life care?
Okay, thank you, Jason. And thank you, Dr. Akhil, for this opportunity. It's always great to be part of such webinars. And again, even more happy when it is conducted by somebody as close as Dr. Akhil. Coming to the topic proper, what EOL, we are dealing with out of hospital cardiac arrest, which we told that is a gray area. And on the top of that, this EOLC in the ED might be a more gray area. So who is first defining who is an end of life care patient, or which patient can be designated as end of life care patient, maybe the first thing. So I looked at different literature, and different literature give different definitions. And one practical definition that we could use that I found in the NHS guidelines was a patient who is likely to die within the next 12 months, maybe he can be considered. That is the all other definitions were more subjective. This was something more objective. A patient who is likely to die within the next 12 months might be considered as a patient, an ideal candidate for EOL. And again, there are 4 kinds of death that happens to a patient. The one is a sudden death, like a patient without any comorbidities or no much of a comorbidity. There is an abrupt decline without any preceding events, like where you have an IC bleed, a severe massive IC bleed, which you think that the patient is not going to survive. That is one kind of death, or that is one kind of end of life patient you are going to encounter. Another patient will be those with terminal illness. There had been a long history of illness, but there is a relative rapid decline at the end, towards the time they come to the emergency department, like a patient with a non-malignancy who suddenly has a sudden decline. So that's the second class. And maybe the third class is those patients with organ failure, like a patient with COPD, a patient with CKD, or a heart failure. The decline is gradual, but it is punctuated by these exacerbations. And after these exacerbations, the return to the baseline is never quite achieved. That's a third group of patient. And the final patient is those frailty, a patient who are, there is a slow decline, that is the extremes of age. The patient has dementia, and they come towards the end of life to the emergency department. There are 4 kind of patients to which the end of life care can be applied. And out of this, those old age patients with dementia and all, that might be the group that is easiest to handle for emergency physicians and easiest to convince to the bystanders as well. But the sudden deaths and the those who had a recent decline, it will be very difficult for us to convince the bystanders or convince ourselves that we are going for an end of life care. Again, who is going to take the end of life care decision? That was the second part of the question. So you have a patient who is, when it comes to already a patient with an organ failure or a terminal illness, it is maybe it is more or like it's more of a combined decision. That is, the bystanders that already know that the patient is having such illness, and we are reinforcing that people might not survive, or aggressive resuscitation might not be useful for these patients, and they agree. But when it comes to a sudden death, like the patient is having a massive IC bleed, who was otherwise normal maybe 10 hours back, or maybe 10 minutes back, and he is having an IC bleed, and you are convinced yourself that this patient is not going to survive. So in such cases, you might be the one who wants this end of one, who wants to keep this patient in EOLC rather than the bystanders. So it might not be totally a shared decision, but again, you should be able to convince the bystanders that you need to do this.
Sir. Hello.
Yes.
Yeah. So coming to the next one. So most of the time, the people coming to the ED will be looking for some acute care. But coming to the patients at the end of life, what would be the reason for these patients coming to the ED?
Maybe I have answered that second question along with the first question, I guess, because there are, what I told, there are 4 classes of people, and 4 of them come for different reasons. There may be the patient with an old age or dementia, they may be coming for some, maybe an UTI or even a small illness, but they are they are in the extremes of age that you are not going to escalate the treatment, even the bystanders, and you are happy not to do that. That is one class of people. Then the organ failure patients, as I told, they usually comes to department for the exacerbations of their underlying organ failure, maybe a COPD with a COPD exacerbation, a heart failure patient with a acute pulmonary edema, or maybe a CKD patient on dialysis with a catheter-related infection, and maybe they already had a failure. They are living with that, and on the top of that, a new infection or a new something is coming for that patient. So those are the patients that usually reach in the emergency department, and in which you might have to take the ULC decision. And again, the another class of patients is the sudden cardiac death patients. And not the sudden cardiac death, the sudden deteriorated patient, like the patient who had an IC bleed, or a patient with who had trauma, which you feel that you and the team feel that this patient is not going to survive, like previously discussed in the traumatic injury, a decapitated patient, a patient who is having his brain matter all over his hair. Such patients, you know that this patient is not going to have a fruitful life. So for such patients, that might also be the reason for them to attend the ED. So you can't tell what exactly the UOL patient comes to ED. Sometimes they, after coming to emergency department, you label them as EOL, or maybe already labeled EOL patient comes to you with a different new complaint. That's how you can expect a EOL patient in your emergency department.
Okay, sir. So, so what can be done for these patients, and what are the challenges in treating these patients, sir?
What can be done for the patient is always tricky. Like, being emergency physicians, our enthusiasm is always to resuscitate the patient. Our aim is to prolong life. However, we should also recognize that alleviating the suffering and prioritizing the quality of life is just as important as resuscitating the patient. And maybe when we start our practice as emergency physicians, we always think that ED is the wrong place to die. But it's as you start practicing more in the department, you come to know that you come to believe that ED is not the wrong place to die, and it is better. It is providing a good death is also an ED physician's responsibility. And end of life care should help a patient to live as well as possible until they die, and to die with dignity. And that term is important, that you should help the patient to die with dignity. So usually the emergency physicians are over enthusiastic to resuscitate every patient that comes to the department. But when it comes to the EOL, those patients you recognized as EOL, end of life care, end of life. So such patient, and lesser aggressive approach might be the best that you could do for the patient.
So coming to the last part, the care, sir, I think you have already said the type of care the patient need. So, so is it possible that we can give a palliative care in ED? As a palliative itself, they suggest that dying, it is important for the patient to believe that dying is a normal process, or you should convince the bystanders that dying is a normal process. So is it possible, or what is the extent of possibility of palliative care in ED, sir?
Maybe until recently, these palliative care services were largely unavailable in our emergency departments. But maybe over the last few years, there have been increased awareness among the ED physicians, and in fact among the palliative care physicians as well, regarding the need to initiate a palliative care right from the ED, emergency department. And again, the changing realities of our patient population. Most of the patients that attend the ED these days are the really old age, the extremes, the upper extreme of the age. And this changing reality of our patient population should prompt us to adapt our practices, and maybe to focus on the patient goals and preferences when dealing with sick patients in ED. So maybe in our department, maybe in the 3 years back or 3.5 years back, we were not availing the services of our palliative care department in our emergency department. It was very rare that we see a palliative care doctor in our department. But maybe we can proudly say that nowadays we make use of them really well. Whenever there is a EOL patient that comes to the department, we make it a point that they get involved. So it gives a better directive for that patient of how to spend his last days. And again, I think all the doctors should be palliative. Doctors should also be palliative doctors, may it be emergency physician or whatever be the specialty. So we should, all the emergency physicians should be trained in some sort of palliative medicine as well. And we are trying to train most of our ED doctors and nurses alike in the palliative. There are some courses that is being run, like 2-day, 3-day courses. We are making it a point that all of us are, we have some sort of exposure to palliative care medicine. And again, we can, if there are no palliative care doctors, those centers can actually use palliative care nurses, which are now more available than previously. And we are proud to tell that we are using that in our emergency department, and it has made a lot of difference.
Thank you, sir. Thank you so much. Thank you for giving us an insight on another gray area, that is the end of life care and emergency. Moving to the last topic, out to Aggie.
Yeah. Thank you, Jason.
Thank you, Dr. Nirmal, for this wonderful session. As you know, we from the initial part itself, as emergency physicians, we are focused on resuscitation, but now the scenario has entirely changed. And the last topic of the day, and this is one of the most awaited topic of the day, that is medical legal aspects in out of hospital cardiac resuscitation. Sorry, ma'am, I am very much sorry because I made you to wait 2.5 hours. Because we actually discussed about, we planned that topic in such a way that we'll be discussing this aspect at the last, so that everyone can ask questions, but it becomes so elaborated, ma'am. Sorry from my heart, actually, ma'am. And this is the panelist with Dr. Srikumari, ma'am. She's currently working as a professor and HOD at the Department of Forensic Medicine at Karakoram Medical College, and most of us will be knowing she's a retired JDME. And next, the panelist will be Dr. Ajit Venugopalan. Sir, are you there? Actually, he was there in the airport.
Still getting into the flight. It's okay.
Sorry, sir, I made you wait also.
No problem.
He's the CEO and group head at the Caritas Hospital, and we'll be directly going into the session, sir. Ma'am, this is basically a case scenario of discussion. So, a 70-year-old patient who had a non-case of CAD, severe LV dysfunction, type 2 diabetes, hypertension, status post PTC on drugs, with a regular follow-up with the hospital physician, and last visit yesterday was brought to ED in cardiac arrest at 8 a.m. with bystanders telling the patient suddenly collapsed 15 minutes back, and the ED physician started resuscitation. ROSC not attained after 20 minutes of resuscitation. The rhythm check continuously showed asystole and adrenaline was given every 4 minutes, with ABG showing severe metabolic and respiratory acidosis. The patient was able to do his routine activities with only history of dyspnea on exertion, and that is a sudden event. That was we meant to make this case. Now, is it out of hospital cardiac arrest or BD, ma'am? That's the first thing we need to know.
Well, thank you, Akhil and team, for including me. Well, this part has already been dealt with because it is already stated that it is not, though people say the patient collapsed 15 minutes back at home, whether it was collapse or whether it was actually cardiorespiratory arrest cannot be assessed unless the person who was attending knew very well what was happening to the patient and had a medical background. So, and it was already stated that it's always better to start resuscitation in this situation, though whether unless there were telltale signs of death, like what as he had, Vimal sir had said regarding rigor mortis and postmortem changes in the eye as well as in the circulation, that is the postmortem lividity. Then again, the time of death is always the time when the death is declared. Because even in brain death, when you are contemplating, what should I say? When you are contemplating organ transplantation, it's always the second brainstem declaration that is declared at the time of death. So the time of death is the time that you have seen, and not what other people think it is the time. Because when we declare the time of death, it should be based on our findings. Then is there any criteria in which this case is not an MLC? Now, normally any case where you cannot, where you are not certain about the cause of death, whatever he is suffering from, and even when he is on regular follow-up with the hospital physician, there are situations when problems can arise later, especially if he has left a large legacy, or if he has handed over whatever legacy he had to one of his relatives and not shared by the others, and then the whole trouble begins. They can allege the doctors are having colluded with the relatives who have brought, and so the trouble begins there. So what I normally advise is that if you are not sure about the cause of death, it is always better to make it an MLC and leave it to the police to decide whether what is the next course of action, because every case of a death, broad death case or out of hospital cardiac arrest, if the relatives are able to convince the police that it's a case of a natural death, they can release the body. There's no harm in that. The other thing is that there are situations where people have, with all these comorbidities and all these complications, have been killed in order to relieve them of the distress of having looking after them. So I'm basically I would always tell my students that it's always better to be on the safer side and leave. If you're sure about the cause of death, fine. If you're able to certify the cause of death, fine. But when you're certified, you must have enough data with you in the form of laboratory reports or in the form of clinical findings to suggest that it was only a natural death. Because there have been situations where bodies have been exhumed even though the death was declared as a natural death by the doctors. So that is with regard to the criteria, whether it's not MLC or not. Then with regard to very often what they allege is that, apart from what you have said, is that there could be situations where they feel that, when though the patient's relatives are expecting death, but when they see the process of dying, they get all worked up, and then they want something to be done, because they cannot just watch the whole process of dying, lying down and just take it in their stride. It's very difficult. Even for doctors, it is very difficult to just simply sit back and see the process of dying. So for the common persons, it is even worse, especially when it is your very near and dear ones. So in such situations also, they might bring to the hospital, and sometimes even to get rid of their, the guilt of not having looked after the patient while the patient was alive. They ask for rigorous, resuscitating activities. The first thing that you need to say in such situations is that not resuscitating a patient who's in the process of dying is not a crime, because generally, as far as one of the sirs said, it is not only necessary that you have to the right of life is not just resuscitation, but you should see to it that he has a healthy life and he lives with dignity, and that is also enshrined in the constitutional right. But if you tend to make the life of the patient very intolerable, awful, or unsustainable, or the CPR is invasive, painful, distressing, and undignified, then you are showing lack of dignity to the person dying. And naturally, there's a tendency to project all their frustrations on what you have done, so that it's a type of a mental coping. So in such situations, first thing you need to say is that you have to educate the patient and say that, first of all, withholding CPR in situations where there's no chance of a dignified life is not a crime, because we are doing real service to the patient in such things. And especially sometimes and there are situations when things can be more harmful, and sometimes it's better left doing nothing for things not to become worse. Then with regard to the legal aspects, already everything has been
Ma'am,
said.
just I have a doubt with them, ma'am. In the case of this time of death, ma'am, regarding if you start as ma'am, as it told, we will be we will be making MLC for almost all cases of BDS, because we can't make sure that there is any foul play or anything. We can't make sure. But it's a private hospital, and most of the private hospital, Dr. Ajit may be having some inputs, because in private hospital, when we start writing MLC for all brought dead patients or all out of hospital cardiac arrest victims, then I don't know whether if suppose a 19-year-old woman who is a bedridden for last 6 to 10 years, and we make them to do MLC, then what usually happens is the situation is getting worse actually in the most of the emergency departments, not like in the government hospital. Dr. Ajit, you are the CEO of the hospital. You may be knowing the scenarios, because when we start doing when we start making all cases MLCs, then the management usually tell next time they will not come to this hospital, because they just want the patient to be declared death or not. So, in how to tackle that situation, both from Dr. Ajit, are you there?
Yeah.
How to tackle these situations, sir? As ma'am told, we always follow the safer side. But as a CEO of the one of the major hospital in Kerala, how's your point, sir?
Another thing is, Madam has put it very clear that about two things. If you know or if you can assess the cause of death in any way, then it is important, or then it is a point that you can give the cause of death. But most of the time, what happens is, from a clinical side, we are not able to mention the cause of death, and we have no clue about what has happened. The age, I would say, is just a number, because if a patient who is around 60s without no comorbidities, no other clinical conditions, coming to the ED within a cardiac arrest scenario, then I would definitely put it as an MLC, because the patient is otherwise healthy. There is no other comorbidities mentioned. In this particular case, there is another thing is, in particular case, I would say, there's a severe LV with PTCA, patient presented with similar symptoms yesterday to the ED, and there is all a background history which points us that there could be a possibility of a cardiac issue that has happened recently. So that is one thing where you can actually drop down a cause of death if you don't suspect any other clinical signs or clinical evaluation to point out that there is no foul play involved. So it is important that when you are assessing such cases, you don't not only assess about the signs of death or signs of not to resuscitate signs, which Madam also explained. It can be cyanosis, it can be rigor mortis, it can be anything for that matter. If there is signs of death is present, along with that, you have to also examine for any other marks or injuries or anything which can point out to the fact that there is a foul play involved. Then the only thing that happens is totally a toxicological analysis, whether it is required at certain times. Again, it all depends on the clinical accumulum that you have obtained after evaluating these cases. Then the other point that you have brought in is whether all elderly is coming to ED, whether you need to put an MLC. Again, I would say is that it depends on the history that you have with you. It depends on the situation that you are in. It depends on the clinical details that you have obtained from the patient. It depends on the histories that you have obtained from multiple relatives, and it also depends on the fact that you have some history to back up your details. If such things are there, then we don't need to make it an MLC, and you can probably put down as a whatever suggesting as a cause of death. But if you don't have any of those, it is always better and safe from the hospital point, and also more than hospital, I would say it is always better and safe from the clinician point that it is marked MLC, because of the fact that if something happens, the first person to be asked and called is the treating clinician. That can be a ED physician. So at that time, court is not going to blame you for not making an MLC, but court is going to blame you for not evaluating or missing out clinical findings. If there was, if the postmortem or if there is something that has come up later on, and that suggests is contradicting your clinical judgment, that is where your court is going to ask you. Otherwise, court is not going to ask you whether why you did not make an MLC. That is just a legal formality. But your clinical judgment, if you can support it completely in the court, then you are on the safe side. And one more thing that I need to add is, most of the time when I have seen things or evaluated cases, what I've seen is that MLC cases are better documented than non-MLC cases, as even if it is a broad debt. So at that point, if it is a patient is made MLC, your documentation is very clear. Whereas if it is a non-MLC, if you have a proper documentation like an MLC case sheet with all the markings, everything, even a small injury is also marked, then you are on the safe side even if you did not make it an MLC. Most important thing is proper clinical evaluation, proper history, and proper judgment of you suggesting that it can be an MLC or not, and that is rest of this is a clinical judgment that you take. And if you make it an MLC, just one more thing I need to put in: don't mention or don't put it like pending autopsy. Autopsy is a word not used by doctors from ED at least. You can say it is an MLC. Let the police decide whether it requires an autopsy or not. And whenever you counsel the relatives, also make sure that you talk in such a way that you tell them that we can't ascertain the cause of death. As a result, we need to make it a medical legal and we need to inform the police. Police will decide on what to do. The next steps are, and there we will give all the details. And if you are supporting details to give, then the court police can decide on what the other further action is. And never mention even in your case sheet autopsy pending, because if you mention autopsy pending, even the police does not have an option that to relieve the body from autopsy, and the police can put it on you that your clinical judgment suggested that the body requires autopsy. So it is important that you balance all this together and mention, to be on the safe side, mention as MLC, inform police. That's all that you need to mention.
Thank you, sir. Ma'am, I just one more point, ma'am. Just a doubt regarding this. When we have a clear-cut idea that this patient is not going to be an MLC, suppose I am declaring death in the emergency department, but still I am not having idea of what's the cause of death. Suppose this patient can have a lot of cause of death, but still I am not suspicion having with my thorough clinical examination, I didn't have any suspicion of foul play, and I want to have declare it as a normal death for him due to some cardiac arrest or any cardiac issues. So is it mandatory for me to identify the cause of death in the emergency department, or if we can't identify, should I go for an autopsy or a pending autopsy or a MLC for that? Only for identifying cause of death, ma'am.
The thing here is, normally any person who's dying should have a cause of death. That is what the law says that. And anybody not having a cause of death requires inquiry. The other thing is that normally even the WHO has published guidelines how a body should be examined before certifying the cause of death. There is a small booklet available how they should be, and they have prescribed the protocol for that. Having done that, MCCD also says that every case need not have a cause of death. That is also there. Every case need not have a cause of death. What we are concerned is that there is no foul play. So, as sir said, I didn't talk about autopsy. I only said inform police. That is it.
Sure,
and the police can come and question you also, and you can say you have not found anything to suspect any foul play. But the fact is that you are not able to certify. That's all. The police can definitely take up the matter and can release the body, provided the police is convinced. Something which you are not able to convince yourself, naturally the police also will not. That is not your lookout. The problem here is that death can occur even without a cause of death. That's what I understand. Ajit sir, I hope you will agree. You subscribe
Yes,
to my view?
Yeah, at times we may not be able to put down a cause of death, but that is okay. That if because don't give, if you don't have the exact cause, like you have mentioned, if a 90-year-old patient who's coming to, you don't feel it as an MI. Cardiac arrest is not a cause of death, or respiratory arrest is not a cause of death. So don't write such things which will create more issues to you. You can certify the patient is dead, and the yellow sheet or white sheet that is there, they can produce to the panchayat and they can get a certificate from there.
Exactly. Even there are so many deaths occurring at home where there is no cause of death, there is no medical certification. Still, it's okay because the panchayat has got the village office has got a way to find out whether there was any unnatural death, and we get certificates. Even in the case of my own mother, there was no medical certificate, but I got a death certificate without a medical certificate at all. She had not been to a hospital because she had She was demented and she had a degenerative disorder. She just died. No medical certificate at all. Even I didn't produce any medical certificate. There's no issue. So the medical certificate is actually useful only to prevent any issues for the relatives. But if the relatives are not scared, there's nothing to be scared about. That's why I said even medical death certificate can be issued by the registrar of births and deaths without there being an actual statement regarding the cause of death. So what we need to rule out is that there is no foul play, and that cannot be done in the emergency department unless you are sure you can take the whole burden on your shoulders.
Ma'am, that's the point. You told a blank statement that we can't do in the emergency department. Dr. Ajit, what is your opinion regarding that?
That's what I said. How can, because there are different persons bringing the body. They might be interested. They may have vested interests. They might hide the true story. Sometimes the bodies are brought even by the accused themselves, and we do not know who the accused are.
Yes,
there have been situations where accused has been, when the case was brought as a natural death, and then it turned out to be a murder. And even as the accused was there present by the side of the autopsy room, waiting to know what is happening. And there was a lot of commotion in the mortuary, which I had basically faced because bystanders police police I told them this is a case of bomb explosion, not a railway accident. So they suddenly got a clue that the accused were waiting there, and that our mortuary that we might have to face. But in the long run, it will do you good. And just as you said, patients will not come. Only those patients who are scared will not come. What patients who feel that you're giving good service will definitely come, because when they are bringing the patient, they are bringing for service and not for a certification as to cause of death. That's what I personally believe. Ajit sir can correct me if I'm wrong.
Yeah, definitely, because from an ED point, 70% of the cardiac, I'm just giving a rough number, 70% of the cardiac arrest which is brought to the ED, the relatives want us to do a resuscitation to get them alive, and those part is always there. So it is our duty to give them a proper resuscitation, depending on the scenario that after evaluation. If all the signs of death is there, then better not to resuscitate. So that is also important to take a call. And one more thing, I don't know, legally, I don't know how much it stands, but elderlies which you feel that you don't want to give its MLC, talk to not just one relative. Talk to multiple relatives. Talk to, if they have two sons or two daughters, try talking to them even over the phone, that is okay. Try talking to multiple areas so that you get a better picture about it. And such things, you can at least justify yourself that I did this because I have so and so justification myself. That is what court is requiring. Even if it is an exhumation done, I'm sure that madam can support that. Even if an exhumation, the court is not going to ask the doctor why you did not do an MLC earlier. If you have a justification, that's well and fine. And one more thing I try to do at times is, again, don't have 100% legal standing, is that a written note from the relatives signed by two different relatives, and concurrently we can document that saying what has happened. They should not change the history. That does not have 100% legal standing, but at least we can have a proof if court is called us that this is what they said, and I have a written document to prove it. And it can be signed by two relatives, it can be signed by a witness. You can make it to a proper consent sort of a thing, just to keep it on your file, so that at times if something happens, even in the court you can say this is how I justified my point. That is fair enough. It does not have 100% legal validity, but it is to prove yourself that you have a proper documentation of the history.
Yeah, all you need to do shows that you have taken adequate care to arrive at your diagnosis. Diagnosis can go wrong, but you have taken. But the problem is that there should be proof for that. So the documentation is the key thing. Documentation is the key thing, and very often in the emergency department, documentation is the one that is the most difficult thing, because you have patients coming one after the other. So that is where the problem arises. All that is required is that you have taken adequate care to arrive at a diagnosis. That's all that is required. But the practical aspect is that something which I cannot vouch upon. That's my problem.
That's what madam exactly said is the important point, because most of the time, what about the medical legal consultants we have, why they ask us to put it MLC? Because they know that MLC sheets are properly documented, whereas non-MLC are not properly documented. That is a problem. If you have properly documented like an MLC sheet or with all the findings, then that is well documented and well marked, well maintained, and well presented to the court, that you, with your proper justification, you are on a safe side.
Sure, sure. Sir, ma'am, regarding the DNA DNR status in India, ma'am, is the DNA DNR forms that we usually write in the emergency department in critical care also valid in India? Is there any what about the legal aspect, ma'am?
Yeah, in 2018, Supreme Court had actually legalized passive euthanasia, sort of, and they have agreed upon this living will. So DNR has status, and later in 2023 also, Supreme Court has further clarified when the Indian Society of Critical Care Medicine went to court for further clarifications. So there are guidelines for DNR where the living will exists and where a living will does not exist. It is there, and I have shared with you, those who want, for lack of time, not going to the details.
Sure,
For anybody who wants can have it, because I have shared the whole thing. It is quite clear. It's very simply written. It's quite clear, but a little complicated, because for both there are slight differences. So that's the thing, that it is there. But another thing which I would like to add is with regard to cases where trauma cases which are good sources of organ transplantation, especially when there is an isolated head injury, and when extended CPR is done, and with regard to the expenses to be met. So that is one raw area where the situations can get out of control when people start talking and they accuse the hospitals for having trying to freeze the patients. So in that case, what I would say is that if you can, of course, private hospitals can survive only on the funds generated from the patients. So there will be a point when you feel that resuscitation, if it is to be continued, was only for the purpose of organ transplantation. At that moment, the patient should not be charged. But this is my personal view. If anybody's there, you can contradict me. And thereafter, the hospital will have to meet the expenses. And as per the hospital policy, you can recover it from the recipients if there's a policy like that, and if it is acceptable. But this policy has to be decided after. What the policy is going to be taken must be decided after consultation with the legal advisor. That's what I normally tell, because I wouldn't always say that the hospital has to bear all the expenses always, because it's not possible. It's quite expensive. So that is one area where I think it requires a little bit of discussion, because it's a very sensitive area, and whatever I have said is not absolute. It's highly personalized, and it depends on the case-to-case situation. Then another area which I wanted to draw your attention was with regard to with regard to the CPR attempts being made on the traumatic cases. Again, that requires detailed documentation, because in the court, we will have, especially the persons who, if an autopsy is conducted, we will have to differentiate CPR injuries from the other injuries, because they will always try to mix. And it so happens that CPR and other extended resuscitation methods done will not be documented as is necessary, and then we will find it difficult, because especially if it's a case of thoracic trauma, the differentiation is sometimes very difficult. I have had around 3 hours of cross-examination, just the defense counsel trying to bring all the thoracic injuries under CPR, and I'm trying to defend that it is not CPR, for want of any documentation with regard to the MRI scan that was done previously, the CT scan that was done previously, and the activities that was done. It must all have been done, but not recorded in the case sheet, and the case sheet is the only thing that is available. So that is one thing from my point of view.
Thank you, madam. Thank you, madam. Actually,
I would like to add one thing to what Madam said is especially when it comes to any cardiac arrest. If you make it in MLC, most of the time the faculty who's doing the autopsy would require a brief note, and we give some note to them so that they can do the autopsy. Don't consider that note as just a formal application for autopsy. It is the basic document where the forensic surgeon is going to cross evaluate and find out findings. So make sure that you have a detailed write up where you should be able to justify all the points, including CPR, including multiple punctures of cannulation. You tried putting a center line, but you couldn't. Then you put a femoral line. You have to even mention that, because otherwise it can go as a puncture to the carotid, and that is the
Exactly.
cause of death. So and most of
please don't be under the impression that when we are asking for the records, it is for finding fault. It's actually to defend. 99.99% we are only trying to defend, because as far as we are concerned, what we want to do is to bring the accused to the doc and not the doctor to the doc. We definitely try to defend.
why I'm telling you the central line is something that we normally do in ED
Exactly.
whenever you don't get a cannula. And the problem is, if the patient is in a DAC or something like that, you try putting in a collapse case, you try putting a EJV, IJV, you didn't get it, you're going to prick the carotid, and that is going to bleed out. And that can be one cause of death, and that can easily come as a cause of death. So make sure that we document everything, including if you have done something, if you have sutured something, if you have done anything into the body, from the point it has come to you and till the point you stopped resuscitation, everything should be documented in the case sheet, not in the MLC document. I'm telling in the document that you give for autopsy.
Exactly.
For autopsy,
And
that is
another thing
important.
is that there are sometimes these issues raised by the relatives, especially when they have some problems with the relatives. Even in such cases, the police will ask us. So if we have the records, we can definitely help the police, and in that way they are helping the justice also, because when we give explanations that this was caused by this and has nothing to do with the persons who are looking after the patient, that's also a good thing. So in a way we are helping the other people also. So that's one area which I wanted to include, though it was not asked in your question. Another thing is that people will definitely go in for DNR if you correctly prognosticate correctly. So in order to improve the living will, only the physician can, the treating physician can decide. We can help. No one else can help, because patients, they depend heavily upon the information that is provided by the treating physician regarding prognostication, and that is going to decide whether DNR should be done or not, whether a living will has to be written. And age is not the deciding factor. The chronic illness is not the deciding factor. It is life expectancy coupled with personal value judgments and religious views. So though it is not related to this, definitely the treating physician has a role in deciding whether the patient wants a DNR or not. Okay, thank you.
And one more thing I need to add: certain times what we face in private hospital is, we tell it as an MLC. After clinical judgment, you feel it as MLC. You tell to the relatives. Relatives is like totally against us, and they try to take the body. No problem. Let them take the body. We can document that and give to the police that even without our will, the patient has been taken, the body has been taken. No botheration for you. Just the police will look into it. That will definitely end up in autopsy. So
yeah, that usually happens in most of the emergency medicine departments.
let them take it. No problem. Don't try fighting. Don't try fighting. Don't try creating issue.
Exactly. That was what I was about to say that at the last.
You can only inform the police, actually. They will do the rest.
Yeah, exactly.
No, but you have to, the moment the body is taken away, you have to inform. They have their ways of blocking. Our duty is over. Let them take it away. Our duty is over.
And document
in a
that
way,
in
a
the case
blessing
sheet.
in disguise. In a way, a blessing in disguise.
and document that
The
in the case sheet.
documentation, both of you
And
pointed out, like putting IJV and all of that. We wrote all these frustration, but these lines and all often we will miss in the case sheets and all. That's what usually happens in the emergency department.
Exactly,
But still
exactly.
we will write all the liquid drugs, adrenaline, entropin, everything we will write. But still, the last thing, the putting lines and all, most of us will forget because
Exactly.
that's the thing
Yeah.
we give least priority after the
Exactly.
restoration.
And
And
one more last point I want to add is, at times, very rarely, you have done everything, you got every history, you felt it's normal death, you give the body as a normal death, you did not mark an MLC. After 10 minutes or 15 minutes after the patient leaves, someone comes to you and gives a totally different history. And then you have a doubt, okay, whether it's MLC, I've given the body and blah, blah, blah. Don't bother. Document that again as a new time. Document it again. Inform the police that I have a doubt with this, and then you can raise an MLC. It is okay, but the time should be don't cut your case sheet, don't correct your case sheet. Post that time someone came, his name, his relation, what you got the history, and that with just judgment, I'm informing the police for further proceedings, and that needs to be done. And if
these are the
at
things we
all,
usually face in the emergency department, sir. Actually,
and
that will
if
happen.
at all you are cutting, make sure that you countersign that with your official sign and seal, because in court of law, if a small cut is a big concern. And so if you're cutting, just cross sign with your official sign and put a seal, then that is accepted.
A single strike, that's all. Don't use
Yeah.
corrections to it.
Okay, ma'am. Okay. Thank you, ma'am. Because when we had this topic, the most important aspect is actually like this. Even though we arrested the patient, we will do a lot of things. At last, many of us may end up in court. Actually, then the scenario will be entirely different. Actually, then they do not ask why do you arrested, why did you give drugs, and the scenario will be entirely different, and they will be asking different questions. So it usually happens in the emergency department as that may be the reason. I think, ma'am, in government hospitals, I work. I did my PG in Calcutta Medical College, and we usually have a dictum that all brought that we go for an MLC because because we can't do a thorough examination
Yeah.
of patients in a government scenario, in a health center or in a taluk hospital, whether we have to look for we don't. A single CMO can't do anything. So that may be the reason we go for all MLCs. But when you come to a private hospital, still we may go for all, but still there are scenarios in which we may declare that from our side. So thank you, ma'am. Thank you, sir, for
Thank you so much.
Ajit sir. You are in the aircraft actually. Thank you for joining from there, ma'am. We made you wait long, but still it's one of the best session we had in this serious webinar. I think we have the senior faculties with you, Andrew sir, Chandini ma'am, and ma'am. Andrew sir, are you with us, ma'am?
Yes, thank you.
I have got one doubt, some clarification.
Yes, sir. Yes, sir.
Time of death you are documenting in a so-called broad death. Madam said once you certify, at that time you put. The problem is we don't know actually when did it happen. That is one thing. Second, in a hospital, only, especially in a government hospital, only IP patient can give a death certificate. There again an issue of choice. These are the two points I would like to get a little more clarification. Often it is very difficult to get correct answer.
What I said was they might have said that there was no signs of life, but we can only depend on the findings that we have seen at the time of when we have examined. We cannot, what should I say, paste it backwards. So that's what I said. The time that you have seen signs of death, that is the time of death as far as you are concerned. Is that what you wanted to say?
Normally, what we do is we mention as time of declaring death.
Yeah, exactly. That's what I said. Time of declaring death.
Declaring death.
As far as we are concerned, it is the time of death.
Yes.
Ma'am, when we consider for the organ donation and all, should we consider this time only, no?
When organ transplantation is the second declaration that is declared as the time of death. That's what is given in the Organ Transplantation Act. The second declaration, not the first one.
When we logically think, it will be different, ma'am. Actually, I just asking my doubt.
But if you refer to the Organ Transplantation Act, you will understand.
I'm not telling a contradictory statement. I'm just asking.
Because that is the time when we are pulling off, when the breathing stops. So that is the time.
Okay, ma'am.
Or when the heart stops, that is the time.
Not madam, not like that. You have to certify death, then only you should withdraw the life support.
Exactly, but
Otherwise,
of course, that is true. But in the case of brainstem death, in the brain, you know that's exactly what I'm trying to say. But though I said it is when the heart stops, it is the when the apnea test is positive. That is the time. Second test. First one la namukku positive aayittu kittum. പക്ഷേ എന്നാലും for as per law it is the second one, sir. That's why I said that's the second time.
Confirmation you have to do twice and then only certify.
What is it?
Like for the confirmation you have to do twice 6 hours.
അതെ പക്ഷേ സെക്കൻഡ് ടൈം ആണ് ടൈം ആയിട്ട് എടുക്കുന്നത്. ഫസ്റ്റ് ടൈം നമുക്ക് അറിയാം ഒന്നും ഇല്ല മരിച്ചു എന്നൊക്കെ അറിയാമെങ്കിലും സെക്കൻഡ് ആണ് എടുക്കുന്നത്. So that's if we accept this in any situation, nobody will find fault with us. That's why I said it is a time when we declare it.
Okay, okay. Thank you, man. These are all actually new information because we always have doubts in these questions. Actually, these are all new information for most of us, maybe. Thank you all these senior faculties, all faculties, for joining us for this webinar series. We actually planned for 2 hours, but it extended up to 3 hours. But I think it is a very informative session. Andrew, sir, what is your opinion, sir?
Only thing is just too much. That's why I suggested put it in 1 or 2 sessions separately.
Sure, sir. Next time, this is the first session that's happened. We had a lot of topics and a lot of faculties, and that's why it's extended up to 3 hours.
In 1 2-hour topic.
Sure, sir. Next time we'll be going to an 1 hour and 2 hour topic, and we expect these faculties also. Chandi ma'am, thank you, ma'am, with us.
Raj, Andrew sir, that is the problem with Akhil. I always ask him to reduce the session. It will continue. You have to reduce
Can I leave? Because can I leave? I have another important meeting. Can I leave?
Sorry, ma'am. Sure, ma'am. Thank you, ma'am. Thank you.
9 o'clock. So I'm already
Thank you,
10
ma'am.
minutes late.
Thank you.
Thank you so much.
Time, Akhil, next time. You cannot.
Sure. We will keep time next time, sir. Because all our informative section, we can't make anyone to stop. That's the problem. Next time, we will definitely cut short into 2 hours, ma'am.
Okay.
Good night.
Good night, sir. Thank you. Good night to all. Thank you, sir. Thank
No,
you, sir.
word of congrats to Akhil and the team PKDIMS for organizing this. Yeah, because getting all this faculty together and putting it a schedule itself is a difficult task.
Yes, sir.
So congrats to the entire team for organizing it.
Thank you, sir. Raju, sir. Thank you, sir.
Thank you.
Thank you.